Welcome to NAHUC's Virtual Lending Library. NAHUC is a professional organization for health unit coordinators and other healthcare professionals performing similar tasks. NAHUC is the provider of professional development for healthcare team members. NAHUC is pleased to offer the webinar Mental Health, the Shrouded Pandemic as presented by Froedtert Health in Wisconsin. We are grateful to Froedtert Health for providing this content. This presentation first debuted in October 2022 as a continuing education webinar offered by Froedtert Health. Information about obtaining NAHUC content hours through NAHUC's virtual lending library can be found at the end of this presentation and on the NAHUC website, www.nahuc.org. That's www.nahuc.org.
I know I can't do Chris's intro justice, but if you guys do want to stay on schedule, Chris or Janelle, if you can hear me, I'm willing to present first. That would help. I know you guys have a lot of presenters and material. As I said before, I cannot do Chris justice because he has been with his team and Janelle, etc., have been tirelessly working to put this together, reaching out for months and months for support of this very important presentation. And on this day, I know it's a two-part series. So good morning, all. I am Dr. Belina Shaw. I am a senior medical advisor at the Substance Abuse Mental Health Services Administration. I gave Chris some long and drawn out bio of my, that I'll do a quick overview of. I went to Yale for college, went to University of Pittsburgh School of Medicine for medical school, and then after that I went to the University of Maryland / Shepherd Pratt program for psychiatry, adult psychiatry, and later trained as a child and adolescent psychiatrist. Decided that I had a love of learning, or I had some other issues, and went back to school at the Johns Hopkins Bloomberg School of Public Health for an MPH, where I was an addiction and overdose fellow and also became board certified in addiction medicine. So I like to call myself a bit of a jack of all trades psychiatrist, and excited to have joined SAMHSA within the Department of HHS. And I am relatively new to this position and excited to, this is actually my first formal presentation as a Fed, as they like to say, as a federal employee. So I thought that for this morning, as somebody who has just come from the field, prior I was the medical director of a local health department's behavioral health system. And have done I've done clinical services in pretty much almost every clinical setting, but I feel like in all of that, I did not really get a true appreciation of what SAMHSA is or does. So I feel like this is in this sort of transition presentation from the into my federal employment. I just thought about what would I like to know as a community member who is involved in behavioral health or not, as far as what do our taxpayer dollars go for, and really what are the resources available to somebody who is either in need of services, the training and TA for the provider field, just in general, an overview. So I am going to share my slides, and this presentation is called SAMHSA from Policy to Practice. And let me get myself in the right view here. Can folks see the slides? I see them. Okay, great. So I am going to then minimize some other stuff, including my face if possible. I guess I can't. And I am going to go through this little presentation here. SAMHSA from policy to practice. Feel free to, I'm a little bit off with the timing, so feel free to ping me, Janelle or Chris, when I'm starting to go over and or getting close to the end, since just because you might want to adjust your day a little bit. Okay, so here's an overview of my presentation. So I'm going to talk a little bit about SAMHSA as a whole, and then highlight some major SAMHSA initiatives, and then follow up with some available resources in the field. So, I'm just gonna, one actual thing is I did have a, sorry, I'm gonna stop sharing because when I went to share my screen, I didn't make sure I shared audio, and I do have a video, so I just want to make sure I did that. So I'm gonna go back and share. All right, that should then be. So once again, I'm Dr. Belina Shaw, SAMHSA from Policy to Practice, and we're going to go over this slide deck here. It's overview of SAMHSA, major SAMHSA initiatives and highlights, and of what resources are available to the field and the community. So what is SAMHSA? The Substance Abuse Mental Health Services Administration. That is, so we are an agency of the Health and Human Services. And you can see here, you'll probably, no one's going to read this whole extensive org chart, but I just wanted to point out some other agencies that you might be familiar with. So the FDA, the CDC, the NIH, these are all agencies that are under the under Secretary Becerra, the Health and Human Services division of the government, and we're here. So we're an agency just like the rest, but we are a smaller agency and have been growing, especially lately, as our nation has been focused more and more on behavioral health. Our mission is to reduce the impact of substance misuse and mental illness on America's communities. And our vision is to provide leadership and resources, programs, policies, information, data funding, and personnel to advance mental and substance use disorder prevention, treatment, and recovery services in order to improve individual, community, and public health. So how do we do this? So, we have a political appointee who is an assistant secretary, Dr. Miriam Dolphin-Rittman, also from Connecticut and Yale, actually, and has joined the team under this administration, has really been a very transformational leader in this age, in this post-pandemic, if you will, era with respect to behavioral health, and has really focused on expanding the role, scope, and relevance of SAMHSA. So she has some strategic priorities and cross-cutting principles within this administration, and I just want to go over them. So the first one is preventing overdose. As we know, we have been in an overdose crisis for about a decade or so, and although the data trends up and down at times, it's still not in the direction overall it would like to be. And when we look at health disparities, we know that, for example, African Americans are disproportionately still rising in those rates. Enhancing access to suicide prevention and crisis care. And I'll talk a little bit more about that in the presentation today. But as far as enhancing access to suicide prevention and crisis care, there not only is the 988 initiative, but in general, these two areas are our mortality in behavioral health. When you think about health, I'm a physician, so I've trained in the rest of our field that we think about the M&M, if you will, right? The morbidity and mortality. And a lot of behavioral health is morbidity and individuals having a poor quality of life, poor potential. And that is what recovery is about, is that we foster and want to encourage recovery so that people can overcome that through their recovery process from their behavioral health condition. But overdose and suicide are our mortality. And we can't forget that behavioral health concerns can be fatal. And I think that these two are also quite tied in some ways as well for many. So, you know, just this thinking about, especially from a hospital perspective or a major hospital system perspective, that these two areas are mortality and costly to our society, both in human capital and as well as financially. Promoting children and youth behavioral health, number 3. As a child and adolescent psychiatrist, I do realize that a lot of times that our children are overlooked in developing systems and developing developmentally appropriate systems and needs for them. And that is a focus of this administration. The next one's integrating primary and behavioral health care, also quite relevant to this group. You know, if we look at the data, the people that have behavioral health conditions are often some of your most costliest, are coming in and having poor disease self-management, and also have a higher risk of mortality when it comes to, say, post-stroke depression and post-stroke or post-MI depression, et cetera. And just the quality and quantity of life can be impacted by not treating that comorbid behavioral health condition. So this is an important priority. And then finally, is if you don't measure it, then it doesn't happen. It never happened, right? So using performance measures, data, and evaluation in the creation, implementation, and evaluation of all of what we do as well. So there's some cross-cutting principles. Those principles include equity, knowing that, you know, in 2020 with this pandemic, I think issues of equity and health equity really came to the forefront, and realizing that this was not a pandemic that's blanketly saturated our country as a whole, that there were disproportionate impacts, and also with the racial injustice movement, if you will, that has re-risen in this time frame, that equity and health equity have been important, and she wants to highlight that as a principle. And not only just racial, but also other minority groups such as LGBTQ and other minorities. We also have the workforce. Workforce, right? We can't do any of this without having people to do the work. And during the pandemic and the great resignation and et cetera, and then just the fact that there was a pre-existing workforce shortage, and especially in behavioral health, this is an area of focus for the Assistant Secretary. Financing, we're primarily a grant-making organization, grant-making policy type of organization, but grants are not sustainable. So we do want to work with our partners, say at CMS, Centers for Medicare and Medicaid Services, Medicare Services. We want to work with our partners there, as well as other partners, to think about, HRSA, for example, to think about how to make sure that what we stand up and what we establish can be sustained. And then finally, recovery. And there's actually going to be a new Office of Recovery that's focused on infusing the perspectives of individuals with lived experience in all of what we do in SAMHSA. So that's not that just this sort of top down, you know, you have credentials, therefore you're able to tell people everything about this field. This is one of the things that's come out of the opioid epidemic, that recovery is, and the people with lived experience have more value than I think we've appreciated for so long, in both the substance use and mental health perspectives, and that recovery isn't just a symptom remission. It's really people living fulfilled lives. So I'm going to go a little bit over the SAMHSA. This is our organizational chart in a little bit of a graphic way, because, you know, that other big chart was a little bit boring, so I wanted to mix it up. I sit in the Center for Mental Health Services as my position. However, there are 4 main centers, and then there's an office that orbits around this office of the assistant secretary or Dr. Miriam Dolphin-Rittman. So I am in CMHS. There's also the Center for Substance Abuse Treatment, or CSAT, the Center for Substance Abuse Prevention, or CSAP, and the Center for Behavioral Health Statistics and Quality, or CBISC. So we love acronyms in the government. I try to learn a new one every day. But these are the 4 main centers, and I'm just going to say that I'm going to talk a little bit from the perspective of what I know in CMHS, but a lot of this is relevant to the other centers as well, what I'm talking about, and similar types of resources are available for substance abuse treatment and prevention. And I know substance abuse disorder is the preferred term now, but this is, those are statutory names. But I'm going to talk a little bit about this. So how do we drive change? So we provide leadership. So, if people in the government or the community have questions, then we want to be the thought leaders around behavioral health for the country. We do have grant programs. I actually formerly was a grantee at the local level and had a SAMHSA Systems of Care grant, mental health initiative grant, focused on transitional age youth. So there are grants, and actually your state has several grants. The health surveillance and data, so through CBISC, our data box, if you will, from that last slide, they have several data initiatives, and just want to make sure that they do that work that I talked about, as far as making sure that data bubble in the strategic plan is being someone's following through with that. Training and technical assistance. And I'll talk a little bit more about that. And then practice improvement, resource development. On our website, there are plenty of toolkits and guidebooks and things of that nature. And those are available for free on the store. And there's folks that are the only job is to work on developing those. Public education and awareness, making sure that where there are PSAs, we have, communications is asking us about some, a talk with ABC News, just making sure that mental health and behavioral health are not as stigmatized as they were before, and also aware of the initiatives and programs that we have. And then finally, regulation and standard setting. I think the easiest example of this would be our opioid treatment programs in the country, and the methadone programs, that those guide the regulations are coming out of our office, and actually there will be an update pending, but those are the types of regulations that we create. So the main ways that we get money into the community are grants and contracts. So our main grants are, there's 2 buckets. There's the block grants. Each of the centers have a block grant. The CSAP, and us, Center for Mental Health Services, have block grants. And then also there are also discretionary grants. And so we put discretionary in parentheses because they are at the discretion primarily of Congress, and we are implementers of those grant programs. And part of their grant, their language, the regulatory language, as well as the appropriations. But the block grants are sort of stable and set and stone, and those go to states. And then the discretionary grants, that would be the grants that you wanted to apply for, say, as a hospital system. And then also contracts. That includes training, TA, surveys, analytical work. But a lot of this work, for example, some of our guidelines, et cetera, we might get some support by contractually by other organizations to help us get some of these things into the field, and things such as logistics, for example. And so here are some highlights of our major initiatives. So in the area of suicide prevention, especially as a hospital system, from policy to practice, this would be so important. And on July 16th, 2022, we transitioned to the National Suicide Prevention Lifeline to the 988 Suicide and Crisis Lifeline. Just as a show of hands, if you have not heard of the Lifeline, can you say that that I have not heard of the Lifeline, and because I just want to, this is part of our um, sort of quality control. Just make sure that people have not, have they heard or not. Okay, good to know. Okay, yeah. Um, don't know. Roxanne, can you speak? Or Roxanne saying that she has not heard of it either. Okay, yes. So yeah, so good to know. You know, I think most people probably knew of what was formerly 1-800-SUICIDE or 1-800-273-TALK. Um, but a handful of people have not heard of 988. So there was a congressionally mandated bipartisanly, if that's a word, passed that 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 988 be designated um, the three-digit dialing for the former Lifeline with a 1-800 or 1-8 something number. And this is having a number akin to 911. That says not 911, but akin to 911. But it serves different functions. It could be really, I think, important. It's going to be very important as a country for us to be able to centralize and increase access to suicide prevention through the Lifeline services. So I'm going to play this video. Let me know if you hear the sound. Okay. So just a little preview of this. And I thought I shared this video for a couple of reasons. Number one, because, oh, I didn't want to share it again though. The number one, because it is, I think, oh, you can't hear the video. Can you hear me now? Maybe because I wasn't speaking. I just started speaking again. All right. But I showed the video not only because it's a nice little primer of what 988 is, but that also is available online as part of our social media toolkit. And so I just plugged that into the slide deck, but it is fully available from the public facing website for others to use to promote and increase the knowledge and hopefully access to 988. And that's some of the stuff that we do. That wasn't some special presentation that communications made for me. That is something that's available to everyone. And it was in that small linear way because it was actually designed for social media, for Facebook, Instagram, etc. All right, so I talked about the designation of 988, but we really think that this is the transformation of crisis care. And when you think about crisis care, historically, we've seen that about 80% of those who call such lines are resolved on the phone. And then the next step of this continuum that SAMHSA sees and part of the Crisis Now model, as per the National Crisis Guidelines, are that 70% are resolved in the field through mobile crisis teams. And then also that, but that 65%, some may need to go, 30% or so may need to go to a crisis facility or receiving center. This is the ideal model. And that about 65% therefore though are discharged back in the community, and about 85% of them remain stable. And the goal of all of this is to decrease use of the jail, emergency departments, and inpatient psychiatric services. We really feel like community-based services are vital, and there's been too much cohorting of individuals in places that are not designed for healing, such as jail and emergency nor emergency departments, and really don't sustain one's ability to truly recover when you think about the restrictive environments of an inpatient setting. as well as the cost. I will not go on without saying that there's cost. But there's also a youth crisis continuum. There's a youth crisis guidelines that are going through a process of clearance right now for field consumption. But the national crisis guidelines came out a couple of years ago, and the youth crisis continuum guidelines are coming out shortly. And the idea is that there will still be someone to talk to or someone to respond, but with a focus on a safe place to be. And with the idea of a safe place to be not necessarily being a crisis center, that it might be some stabilization supports within a youth's home. And if that is what we are, what we can do and be able to keep a child in the home, then that is a win. Developmentally, that is most appropriate. And the core principles for all of these are that there's safety, equity, that they're trauma informed, that there's peer support infusion, as well as they're culturally and developmentally appropriate. So SAMHSA, I'm not going to go into the details about this, but just an example of some of the work that we've done to get communities ready for 988. And they created some playbooks prior to my coming on. I actually was able to participate in the national convening, though, where they rolled out these playbooks. And they can see that the national partners that were a part of the development of this work. And so there was additional funding to align with the congressional designation. And you could see that the lifelines, that 1-800-273-TALK number, was funded at abysmal amounts up until the 21-22 years, and with preparation of the rollout in FY22. And you can see that this actually is when some of the money started to hit the call centers, and you can see that not only did the number of calls answered, but the answer rates and started to increase. And the answer rates are a number of percent that are answered within a I forget their benchmark, but their benchmark period. I believe it's within a certain number of seconds. But you can see that pretty much all of them are meeting the quality improvement goal now. But you can see also July, when this rolled out, that we had our peak of calls, but still it has been sustained well above. And this line has been around for hopefully decades, actually, in different forms, shapes, or forms. It actually has been decades in shapes or forms. But just the 988 impact is relevant here. And you can see it here once again with the call answer speed decreasing. And also this is the text answer rate. When we talk about the importance of youth in making sure that youth have access to this crisis continuum, that youth are more likely to use text and chat modalities. Text is your cell phone. Chat is like you're talking to your customer service person through the computer. That'll be the chat. And text rates, significantly improved with additional financial funding, as well as the numbers of texts. And the answer speed has exponentially gone down for those from about 20 minutes to 1.5 minutes. I mean, if you think a young person, none of us have patience to look back at checks when you're in crisis 24 minutes, especially a young person. It's gone down to about 1.5 minutes. And the answer rate has improved significantly. Average call answer speed has improved. And so so I just want to say that, this is we can see where from policy to practice, I think this is a great opportunity to see where congressional mandates and funding aligning with the vision of the agency have really been able to make an impact already just at the entry point of the call line. But we do know over decades that youth suicide rates have been increasing. And there's the preliminary CDC data is concerning for such as what they're just released their 2021 preliminary CDC suicide data. And when we had one of our staff members internally analyze their database that is available. There's for public use. And when you drill down to minorities and that actually Black and actually Asian youth, which was an interesting change and trend has increased. But we know that in Indian country, American Indian, Alaska Native youth have and adults have had significantly high rates for a long time. But in 2019, the Congressional Black Caucus wanted to make sure to highlight the importance of the Black youth suicide in America. This has been a sort of silent epidemic, if you will, with the thought that traditionally, being Black was protective in America with respect to suicide. However, that has not been true, and especially Black males, but also as far as complete deaths by suicide, but also Black females with increases in attempts have been increasing, doubling over the past 10 or 20 years or so. And so we do want to just focus on that. There was also, after this panel, also a Health and Human Services a document, and we actually held an expert panel, a technical expert panel in August at SAMHSA to address this issue and learn more about what we can do from other experts in the field. And we are developing a line of work and initiative around that right now. Another technical assistance that is available to everyone is SPRC, or the Suicide Prevention Resource Center. You can Google this right now, and SPRC is a great resource around suicide prevention in our country that's funded through SAMHSA. And then also Zero Suicide, another major initiative around suicide prevention. But also this initiative is actually focused on healthcare systems. So I'm going to go over a little 3-minute video here.
Every minute of every day, suicide impacts the lives of hundreds of people across the globe. It robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, Zero Suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to perfection is the only way to create dramatic change. And it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to Zero Suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, we must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, do you have thoughts that you'd be better off dead or hurting yourself, allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment, as well as caring and supportive contacts either between appointments or as post-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the U.S., they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with a set of practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio. For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero suicide, healthcare that believes no one should die alone and in despair.
And so this is an initiative. It's also funded through, so this generally is funded through SAMHSA, but then there are also, if an organization wants to, for example, apply for a grant to work on implementing this, then we can, that you could do that as well, that you could apply for a grant. And we're actually right now working on actively writing the next presentations. So the next notice of funding opportunities. That video came straight from the Zero Suicide website and is available. And there's that toolkit on the Zero Suicide website has information about how to and look at your organizational readiness and tools on how to implement the model, all free and available to you. Certified Community Behavioral Health Clinics, or CCBHCs. I don't know if you've heard the buzz around CCBHCs, but there's two elements of CCBHCs, or two main buckets, if you will. That there's one bucket of CCBHCs that are actually through a CMS demonstration project, where different states are looking at how to fund this through their state Medicaid program, and then we also provide grants to some programs as to some different organizations that want to create these. There's 9 services with the foundation of outpatient mental health and substance use services, with elements of crisis care, this coordination between primary care and mental health, recovery supports, community-based supports, and making sure that the needs of veterans are taken care of there as well. So a very comprehensive program, has shown great data in improving outcomes, and you can see that there's about 400 of them, or 400 or so across the country. And this is a slide taken from the National Council that provides the technical assistance and evaluation for this. So long COVID, healthcare systems have taken the burden on of the acute COVID crisis, and it's I just appreciate so much what the direct line healthcare workers did in the last couple of years and continue to do as we still fight COVID in a different way and without the same fanfare and praise that healthcare workers were getting from those who were praising healthcare workers during 2020 and 2021. But we are now seeing secondary consequences of COVID, and there's this long COVID syndrome. There's been reported up to 200 symptoms related to long COVID syndrome, but some of them are neuropsychiatric syndromes, including the brain fog, fatigue. A lot of this looks to me, when I think about actually post-concussive syndromes, a lot of this seems also very similar, and cognitive rehab can be helpful for it. But depression, PTSD, obsessive compulsive symptoms, all are challenges that can be associated with long COVID, but also can be exacerbated when people had pre-existing behavioral health conditions. So we know a little bit about this, and we are growing in our knowledge. The Secretary Becerra has developed an office focused on this space, and we had an expert panel related to this as well, and we will be putting out soon a paper a little bit about the neuropsychiatric complications, because it's such a burgeoning area that we really we need to disseminate what we know so that we can learn more and share with people that don't see it as frequently. So here's just a little bit about available resources. There's a treatment locator on the SAMHSA website. And sometimes, with all these types of resource guides, it can be challenging to keep them all up to date specifically, but there is a great starting point for looking for resources. And you might also want to, look at your state and local jurisdictional supports for similar resources, but I think it's a great starting point. Publications. So I talked a little bit about what's available through 988. So we have a store, but not only can you get things for at the organizational level, just to, for say a presentation or your social media, but also you can get buttons and magnets. No, not buttons, they're not really in, but magnets and stickers. Actually, these are available as, I believe, stickers on the There's Hope ones are on the website, so that and those promotional materials can be shipped free of charge. I used to do some promotional work at church, and I would get these from SAMHSA and have the Lifeline suicide prevention cards available and just give them out just free of charge. An evidence-based resource center, that's where you'll find these guides, toolkits. We call them TRIP tips, treatment improvement protocols. We like acronyms. Tips at the government, and then also practice guidelines, for example, can be found at the Evidence Prevention Resource Center. And then also CBISC has their data and reports here as well. So each region of the country, just like HHS is divided into regions, that SAMHSA has also regional administrators. You can see your regional administrator here. I just do want to also say that I believe Jeff Cody is also acting as actually acting as well as the Center for Substance Abuse Prevention Director. And so just great that you have such strong leadership there in region. So region 5. Yeah, that's not showing there, but I think it's region 5. And then also some other TA. There's practitioner training. You can see like the PCSSs, the provider clinical support systems, technical transfer centers. You can just go here and find training information. Here's just some of the highlights of some of the TA that's in just from CMHS, from Center for Mental Health Services. You have a technical transfer center here. This is the regional one. SMI advisor for serious mental illness, gains around criminal justice, LGBTQ Center Excellence, the African American Center of Excellence. I think I have another minority one too, maybe didn't put it. There's also the AIAN one's actually new, Hispanic Center of Excellence as well. The one for veterans, integrated health solutions could be very relevant to the work that you're doing at the health systems level. Eating disorders, aging, the National Child Traumatic Stress Network, a very important network of TA and providers and grants and grantees that focus on the trauma related to our young people. And they have a bunch of resources available as well. And there's 2 new ones, actually, social media and wellness, one that's starting out, and also behavioral health excellence in nursing facilities, another one. You know that nursing facilities strongly overlaps with hospitals, and you often get admissions and discharge issues, and so that's important. Just from policy to practice, I'll quickly go, and I'll try to get your time back a little bit. The Bipartisan Safer Communities Act, or BISCA, was signed into law in June of 2022, and it provides about 800 million additional million over 5 years for SAMHSA programs, for 5 SAMHSA programs over 4 years. Sorry, trying to rush to catch your time back up. So the mental health block grant, I remember I talked about the block grant before, the 2 categories of block and discretionary. That there'll be about additional 60 million a year for each, not for each state, for all the states. And there will also, and that program's about 800 million, just to give you the magnitude of the money that goes out over for the whole country. So adding another 62 million a year is wonderful. The National Child Traumatic NCTSN, the Child Traumatic Stress Network will get another 10 million a year. There's a program focused on trauma-informed treatment in schools, or services in schools. And that's Project Aware. We'll be getting more money. Mental health awareness training. If you've heard about mental health first aid and programs like that, there's money to do that, to have those standardized and high fidelity trainings available to increase awareness and supports for individuals who are able to facilitate or be those gatekeepers, we like to say, getting people into mental health and behavioral care. And then the Lifeline has been getting an infusion of cash, which I talked about before. So SAMHSA's mission is to reduce the impact of substance abuse and mental illness on America's communities, as I said before, Dr. Belina Shaw. So thankful to have you guys here and be my first official SAMHSA presentation. I apologize for, I saw a little typo in there. I hope to get it through quickly, but and I could take a couple questions until Chris says for me to stop, or Jeanette. And any feedback's great as well, just because this is my first presentation with SAMHSA, and I just want to, and I hope that the overview was helpful so that you can understand a little bit about what this federal agency does, and it's not just this pie in the sky kind of entity. Any questions? We're working towards reduction in suicides. We're increasing the calls, but we haven't quite gotten the reduction in suicides we'd like to yet. Did Richard Keller have a question?
Yeah, I did. Can you hear me okay?
I can, yes.
Well, first, thank you for your flexibility, and apologies for the mix-up this morning. So thanks for going first. I very much appreciate it. Second, my question about your talk. You had said something about rising rates of suicide among African-American women in particular. And one of the questions that comes to mind, is there a link between those rising suicide rates and gun ownership?
So that is a good question. It is not completely clear. I cannot completely answer that, but for African Americans, there is for African American males, just like males in general, there's a higher number of fatal, deaths by suicide, and women are more likely attempting. So for the African American women, I would probably assume that it is not that those attempts are not through firearms, because they are more often not fatal. But for African American males, they are a significant number. More of them are fatal, and the number of firearms in multiple communities, especially communities of color, could be impactful there. But I'd have to go back and see, and I don't know if the NVDRS, I have to go back and really, the National Vital Statistics Data Recording System, and go back and look in the NVDRS on the number of gunshots. But I actually think that there might be an association. When you think about firearm ownership, and I wouldn't necessarily always say firearm ownership. I would say access to firearms. And this goes back to why we have to think about being culturally sensitive and how we ask questions. I went to medical school in Pittsburgh, where the first day of hunting season was, at that time, I believe it was a school holiday. It was the hunting season was impactful, and firearm ownership was quite pervasive. And there was but there could be communities where there could be firearm access that we might not ask about it in the same way, even if it's not a technical ownership. You're welcome. Any other questions? Well, Chris, I will take it back to you. Oh, the acronym? Yes. SAMHSA is the Substance Abuse Mental Health Services Administration, one of the multiple divisions out of the Health and Human Services, U.S. Health and Human Services, under Secretary Becerra. Well, thank you guys so much for having me. You're very welcome.
We have a question from Harriet. She could not hear in the beginning. She wants to know what the acronym SAM, SHA.
Yes, that's what I said before. SAMHSA. That's how we abbreviate the Substance Abuse Mental Health Services Administration, SAMHSA.
I can't even hear it.
And yeah, substance abuse is a term that has fallen out of favor. Language matters. We are being destigmatizing and recovery oriented in our language, and so but we do have a bit of an identity challenge because the name of the federal agency is established through statute, so we cannot just simply change it because we'd like to. So so it is the Substance Abuse Mental Health Services Administration, although we do try to make sure that we use focused language around, say, substance use disorders, etc. Sure. So yeah, so substance abuse. So and just the thought is that abuse is a pejorative term. It's not necessarily a term, and it's a stigmatizing term. And so we're trying to get away from terms like substance abuse, but also language, for example, that is not person-centered. So, and this is not just specific to substance use, but for example, an individual who has schizophrenia, or actually in the substance use world, they talk about people who use drugs, not necessarily a drug addict, but people who use drugs. Now, in say the 12-step community, there might be some language where they might say, in NANA, that I am an addict, and they feel comfort in identifying that way, so that prompts change. But I also have had patients in my addictions work that feel uncomfortable saying that, and saying that, I don't want to identify as an addict, but I have a problem with substance use. And so, yes, that is, so as we look at how to make sure that we're recovery oriented, destigmatizing, that it's important. I even think through, say our media work, that, are we talking about mental health or substance use with bleak colors, et cetera, that we want to keep it bright and airy and hopeful, because all of this matters. It all matters. Anyone else? Any other questions? Thank you, Jacqueline, for typing that in the chat. That it's substance use disorders. And that's actually substance abuse was removed out of the DSM, the Diagnostic Statistical Manual. And it used to be substance abuse and dependence, and now it's become substance use disorders, mild, moderate, severe. So it also has changed the diagnostic nomenclature lately as well.
Thank you, Dr. Shaw. All of us at the National Association of Health Unit Coordinators in Froedtert Hospital, thank you for sharing your experience today. Sorry for that snafu this morning, so proper introductions. Good morning, my name is Christopher Anderson, Manager of Patient Systems and Support here at Froedtert Hospital. And I would like to welcome you, a little bit late though, to this first session of Mental Health, the Shrouded Pandemic. This webinar is brought to you by the National Association of Health Unit Coordinators and is sponsored by Froedtert Hospital. Over the course of this webinar, you're going to see the mission and vision of both, and I do encourage you to read them. You'll also see the websites www.nahuc.org and www.froedtert.com. Before the day is out, please visit both for more information. At the end of the webinar, you'll receive a survey in your inbox that will act as your application to continuing education credits, as well as feedback for the webinar. So we were privileged to have an audience spanning coast to coast, and in fact, a few international attendees as well. This webinar, and the one next week, aim to pierce the taboo that mental health fosters. After all, 1 in 5 adults experience a form of mental illness each year. Let me give Dr. Shaw her proper accolades. Dr. Shaw attended Yale University for her undergraduate studies. She graduated with distinction in psychology major while completed her pre-medical studies. She then received her doctorate of medicine from the University of Pittsburgh School of Medicine. In 2007, she moved to Baltimore for her general adult psychiatry residency and Child and Adolescent Psychiatry Fellowship at the University of Maryland, Sheppard-Pratt, where she served as a chief resident of the Psychiatric Emergency Services and chief child and adolescent psychiatry ambulatory services fellow. While in training, she received numerous awards for culturally competent and was an American Psychiatric Association Substance Abuse and Mental Health Administration Minority Fellow. Dr. Shaw later joined the faculty of the University of Maryland School of Medicine. She also was an alumnus of the Bloomberg Fellowship Program in the area of addictions and overdose at the Johns Hopkins Bloomberg School of Public Health, where she received a master's degree in public health. So today we heard from Dr. Shaw from the Substance Abuse and Mental Health Administration, and later we're going to hear from Professor Richard C. Keller from the University of Wisconsin-Madison, and Zoe Schmidt and Ashley Thousand from Froedtert Hospital. But first, we're going to take a break. I would like to thank our friends at the National Alliance for Mental Illness for lending their video library to us.
Hi, my name is Joshua Ryan Brenner, and I am diagnosed with bipolar disorder. I was born and raised in Chicago, Illinois. Never saw my parents together. I got divorced when I was 1. My dad went to prison for a year, and my mom was left, to raise me by herself. Despised going to school. I got bullied. I tried very hard to fit in. I couldn't fit in. I tried too hard. There was never, I don't know, I couldn't really get it. My father would tell me I wouldn't amount to anything. I think you are a product of your environment, that's why your home is so important. I had temper tantrums. I feel bad for my mom because she had to put up with it. When you get older and you see a child in a store throw a tantrum, you're like, damn, did I really do that? Did I do that to my mother? My mother knew that my father did have bipolar disorder. She brought me to a doctor when I was 10 or 11, and the doctor told my mother, your son will never be normal unless he's on medicine. Risperidol, trileptal, Zoloft, Ritalin, Adderall. To this day, my mother is convinced that it was like a magic bean, and she gives me that I'll take this magic bean and all my problems are gonna away, and I told her it's not like that. I think the problem with bipolar for me, at least, is I don't know when to stop. It's either I'm 0 to 100. It's I'm either just going to the top, I'm going full out, or it's I have no interest whatsoever. I can't stay still. I feel I have a hard time just doing a routine over a normal 9 to 5 job. I can't remember the last time I had a 9 to 5 job for over a year and I've made it last. When I don't like a situation or if something's unfair, I get very frustrated very easily. The hardest thing is just being level-headed in moments that you don't feel comfortable in. You can't get away from it. If you have to go to work, right? You have to go to work because your boss isn't gonna care that you are having a mental breakdown. He doesn't care. You're there to work and do your job. I'm very scared to mention that I have bipolar. It took me a while, the past girl I was dating, to tell her that I had bipolar. I've been on a date and I told the girl too soon and she didn't talk to me again. With any problem there is in the world today, it's all about education, So obviously there's stereotypes for every religion or every ethnicity, and the only way to correct people is by educating them. So if you are in a relationship with someone that does have bipolar, please keep this in mind. Have patience and do not be judgmental. If you do that, you'll be all right. But anyone that does have bipolar, we're all built differently. You gotta find what works for you, so keep trying new things. Being diagnosed with bipolar disorder played a huge role in me becoming an actor because I am emotional and it's very natural for me to get into a zone or go somewhere where a lot of people feel uncomfortable, but I'm so used to being in uncomfortable situations that it doesn't really faze me anymore. It's a superpower. Bipolar is a superpower, is what they say, so it's my superpower. My faith in God has definitely gone up. I grew up not religious at all, whatsoever. When I first showed up at this synagogue or they're like, you sure you're in the right place? Because I wasn't wearing a kippah, and I'm like, yeah, I'm here to see Rabbi Levin. They're like, oh, okay, he's upstairs, like looking at me like I'm the alien. You know, now they all know me, and they only want what's best for me. At the end of the day, they want to help one another, and we need more of that in the world. I was looking at the NAMI website, and the thing I really liked is that there's groups that you could talk about bipolar disorder with, and for me at least, I need to be in person, look them in the eyes. So I am so excited to see that NAMI has all these local chapters and support groups. For the circumstances I had, I'd like to think I've accomplished a lot. I might not have all the dollar signs to show for it, but I've definitely lived life and traveled everywhere and hung out with some cool people. I truly believe I always try to be better than I was yesterday. It's like my motto. So you know, I'm not perfect. I made many mistakes, but I try to always be better.
Let me welcome Professor Keller. Richard C. Keller is a professor and interim chair in the Department of Medical History and Bioethics and professor in the Department of History at the University of Wisconsin-Madison. He is the author of Colonial Madness, Psychiatry in French North Africa, and Fatal Isolation, The Devastating Paris Heatwave of 2003, both from the University of Chicago Press, and is the editor, with Warwick Anderson and Deborah Jensen, of Unconscious Dominions, Psychoanalysis, Colonial Trauma, and Global Sovereignties from Duke University Press. His work has been funded by the National Science Foundation, the Andrew W. Mellon Foundation, and the Visiting Scholars Program of the City of Paris. And now, Professor Keller.
Thank you so much for the generous invitation to join you folks today. And thanks for your kind introduction, Chris. I very much appreciate it. Apologies about the mix-up earlier, and thanks again to Dr. Shaw for being willing to step up and go first. I'm going to try to share my screen here. So let's see if this works. Is that working for you? Hopefully. Okay, and I'm going to go ahead and start a slideshow here. Good, so I am a specialist in the history of European and global medicine and public health, and much of my work has focused on thinking about mental health as global health, or vice versa, essentially thinking about global health through the framework of mental health. What I want to talk about today is to think about the COVID-19 pandemic and mental health, to provide a brief kind of historical context for how we think about mental health as global health. Then I want to sort of shift gears and look at the pandemic and global mental health. So in other words, starting with just a sort of basic conversation about the pandemic and mental health, but then putting that in a global context. Finally, I want to kind of round the talk out by looking at a series of confounding or cascading crises of mental health globally, as well as in the United States and in the global north, and to then look at perhaps some room for optimism, some cause for hope in thinking about what can sometimes seem like really just intractable situations. So first, I want to address the pandemic and mental health. There's been, of course, a great deal of conversation about the COVID-19 pandemic and its mental health impacts. A piece in the Lancet Psychiatry about, toward the beginning of the pandemic, described essentially a triple global public mental health challenge emerging from the pandemic. And the authors described that challenge as essentially, first, preventing increased mental disorders and a loss of well-being as a function of the pandemic. Second, protecting people with mental disorders from COVID-19 given their increased vulnerability. And then third, protecting the mental health of health workers. So I want to look at each of these three in turn. Preventing increased mental disorders as a function of the pandemic. If we think about the acute stresses of the pandemic and those acute stress reactions, it's easy to understand why there could be a kind of pathogenic component where mental health is concerned around the pandemic. Many people suffered from fears of infection or contamination. I know personally, I suffered a number of anxiety dreams where I would dream and have a nightmare in the middle of the night that I hadn't washed my hands well enough and was touching my face, those kinds of things. And so these are really pervasive problems. Of course, isolation as a function of quarantine brings with it boredom, anxiety, sometimes irritability, sometimes anger as consequences of that isolation. When those around us die and we don't have the possibility to memorialize those deaths and mourn them properly, that can provoke extensive mourning, melancholic reactions, a whole series of problems linked to grief. For patients who entered intensive care units, there's the trauma of that experience, which one of my colleagues, an intensivist herself at UW Hospital, has described as essentially torture, right? The experience of being on a vent, the experience of being bedridden for sometimes weeks at a time can be an incredibly traumatic experience. As Dr. Shah had mentioned earlier, there are, of course, the neurological sequelae of COVID-19 infection, which are another critical problem. And then there are, of course, the uneven pressures, those stresses of economic loss, unemployment, and increased social inequality that themselves can lead to poor mental health outcomes. In terms of protecting people with mental disorders from COVID-19, we have to recognize that there is a kind of bidirectional risk. COVID-19 elevates the risk of mental illness, as I just discussed a moment ago, but mental illness has the capacity to elevate the risks of COVID-19 infection. So for example, mood disorders can correlate with higher risk of hospitalization and death. And of course, inpatient care in a hospital setting, because of that congregate living situation, exacerbates the risk of infection. So that's another critical area. And finally, protecting the mental health of health workers has been a critical goal from the outset. Of course, health workers suffering from elevated levels of anxiety, feelings of helplessness, fear of infection, fear of spreading the disease themselves. An anesthesiologist colleague of mine talked about how when she would go home after a 12-hour shift, she would just essentially try to decontaminate herself because she feared bringing COVID to her family. There are, of course, the stresses of staff shortages and overwork, which can add to the mental health burden suffered by health workers. And especially at the beginning of the pandemic, a lack of PPE exacerbating essentially all of these potential risk areas. Now, all of these are problems in the United States, but how does this look on a global scale? What I want to do is sort of bracket the pandemic for a moment and take a kind of historical excursion to look at the history of mental health as global health and global health as mental health. So let's take a look at global health per se first. There are very typical kinds of images of global health, which usually depict global health as operating in a kind of one direction. Essentially, many of those images show, as we see here, very often white practitioners caring for Black and brown populations, usually in developing world settings. So I would argue that this is a very limited kind of framework for understanding global health. Which doesn't really take account for the kind of bidirectionality of it. It doesn't account for the complexities of global health. And indeed, when we think about global health, we often think about global health through the framework of infectious disease. So we think about diseases like malaria or Ebola and so on. Again, this is a kind of limited framework for how to think about global health. What I want to argue is that we need to begin to think about global health and mental health and their intersections much, much more carefully than we have historically. This is because roughly 20% of the global health burden is linked to mental health. As my colleague Bob Desjarlais and his colleagues pointed out in a World Mental Health Report, which is almost 30 years old at this point. But this was the document that I think really got social scientists in particular thinking about mental health as a critical global health problem. So what are some of the things that the authors pointed out in this study? Well, first, they looked at improvements in global public health and how those improvements in global public health, like, for example, broadening access to vaccines, broadening access to primary health care, all of this began to boost life expectancy and to boost population as a consequence, which means there are quite simply more people now who are living into the age of risk for a number of disorders, including schizophrenia, dementia, and depression. Now, in developing countries in particular, there are a broad range of problems that can exacerbate mental health risk. For example, problems like violence or social dislocation, broad-scale poverty, increasing drug and alcohol abuse, economic exploitation. All of this can really exacerbate vulnerability to mental illness. Many of these countries, of course, suffer from scarce resources. They simply don't have the finances to prevent to prevent mental illness, that's a typo, to prevent mental illness and provide adequate treatment and provide for containment of mental disorders in developing countries. We also have to note that as we live in a global community, as we have increasing migration all around the world, that means that essentially the human and financial costs of mental illness are shared by all of us, right? That they are not remote problems, but indeed are something that we see on our very doorstep. Now, one of the most important elements of this report is that it considers mental illness. It considers the widespread disorders in developing countries in particular, not so much as a function of culture by any extent of the imagination, but instead as a function of political economy. They're looking at structural factors that are increasing risk for mental illness. Psychiatric interventions, by contrast, have tended historically to focus on culture and the links between culture and mental illness. So, for example, DSM-4, the text revision that came out in, I think, 1994, 1995, something like that, had a section on culture-bound syndromes, which I'll get into in a moment. And then there's another more perhaps historically rich and perhaps more nuanced approach known as ethnopsychiatry, which really emerged out of the 1960s and 1970s. And I'll get into just a couple of details about each of these before turning back to the pandemic. So DSM-4 includes this outline for the cultural formulation and a glossary of culture-bound syndromes. Sort of put bluntly, this is essentially the idea that there are certain kinds of disorders that only appear in certain kinds of cultures. So I'll give just a couple of very quick examples of this. One is a disorder known as LATA. This is a kind of hyper-startle syndrome where essentially you say boo to someone and instead of just kind of jumping a little bit, they will go into essentially a fugue state where you can, it's almost like a hypnotic state. And this is a sort of dissociative and trance-like disorder that is mostly confined to Malaysia, strangely enough. And it's typically something that happens in middle-aged or older women in Malaysia. It's been seen, it's been noted in other places in Southeast and East Asia, but indeed, it seems to be largely confined to this region, and no one really knows why. But other examples of culture-bound syndromes are disorders that, at least to me, don't seem as if they're culture-bound at all. For example, brain fag is a term that was initially used in British West Africa, in Nigeria in particular, under colonial rule. And it describes a condition suffered by school or high school or university students when they get stressed about their schoolwork. So students say that the brains are fatigued. Other symptoms include head and neck pain, pressure or tightness, blurring of vision, brain tiredness from too much thinking. And typically this emerges around exam time. Now, call me crazy, but this is the kind of thing that I see in my students all the time around exam time, and something that I don't think is really confined to Nigeria. Another disorder that's described itself in DSM, Malda Ojo, or the evil eye, right away they define it as not necessarily culturally bound, a concept widely found in Mediterranean cultures and elsewhere in the world. It doesn't sound like that's really terribly culture bound at all. Approaches to the relationship between culture and psychopathology have included what some practitioners have defined as ethnopsychiatry, a sort of specialist branch of psychiatric practice. As Francois Laplantine, a French anthropologist, described in 1988, ethnopsychiatry is the study of relationships between psychopathological behaviors and the cultures in which they appear. On its face, it sounds like, I think, a really interesting set of questions, right? What are the kinds of questions that ethnopsychiatrists ask? Well, one thing they might ask is, what does mental illness mean in different cultures? And I'm sure that everyone would agree here that different cultures have different understandings of mental illness. To suffer from depression or to take an SSRI means one thing in New York City. It might mean a different thing entirely in Kansas. It might mean a different thing entirely in Beijing or in Harare in Zimbabwe. Different kinds of disorders have different meanings and different cultural baggage in different sites and in different cultures. Another question ethnopsychiatrists might ask would include things like, what's the prevalence of different kinds of disorders in different social milieux or in different cultures? And then finally, they might ask the question, how does culture shape the content of disorders such as schizophrenia or depression? So for example, many patients who suffer from schizophrenia in the United States might say that the CIA is trying to read their brainwaves or something along those lines. It might be interesting to see what someone in rural Morocco explains as causing their disorder if they're suffering from schizophrenia. And it may or may not be similar to what we might see in an American patient. Ethnopsychiatry has become increasingly significant because of just absolutely massive population migration that's characterized the past 30 or 40 years. For example, a number of traumatized refugee populations are moving across borders and they're suffering from increased levels of mental illness and turning up in Western hospitals in London, in Paris, in Amsterdam, in New York, or in Madison, Wisconsin. So one of the questions is how to treat these patients in a Western context if they have different cultural ideas about what's causing their mental illness, what might be an appropriate solution to their mental illness, what might be an appropriate course of treatment. How can we help those patients with their compliance with, say, a prescription regimen if they don't understand or don't think about mental illness in quite the same way as a Western trained psychiatrist might. And that brings us to the problem of the incursion of Western training into a non-Western world. How can you bring potential benefits of Western medicine and modern pharmacological psychiatry to populations without necessarily violating their cultural idioms or norms? One of the biggest challenges then that ethnopsychiatry faces is to really essentially understand how culture functions, how it operates for mental illness while avoiding a couple of important pitfalls. One is the relativization of psychiatry, to think that any kind of therapeutic action when facing mental illness amounts to a form of psychiatry. And also, I think an even bigger risk here is to psychiatrize, to make up a word, or essentially to pathologize culture, to look at factors that are perfectly normal within a cultural context and to see them as pathological. Let me explain these pitfalls very quickly before turning back to the pandemic. I want to cite one example of a clinic, the Centre Georges Devreux, on the outskirts of Paris. It's in the northern part of the city in what's called the banlieue. This is an area populated heavily by North and West African migrants and their descendants, where people coming from France's North and West African colonies have lived for generations. But continue to speak African languages or Arabic in the case of North Africans, or Berber, or a language like Wolof or Soninke, or any of a number of West African languages, and continue to essentially preserve elements of their home cultures, their former home cultures. A practitioner named Toby Nathan, a psychologist by training, has assembled a kind of clinical team when patients present with mental illness in this area and come to visit the clinic. And that team includes language specialists, ethnographers, psychiatrists, psychologists, a broad range of 10, even a dozen practitioners who work with each patient. And the goal there is essentially to understand and to try to distinguish between elements of the patient's culture and elements of psychopathology, to try to treat the patient within the context of their culture. It's an interesting idea, and occasionally it seems to even work. But there are some important pitfalls there, where essentially there's the problem of fixing those patients in their culture. To argue that someone whose family has lived in Paris for generations remains essentially West African in their roots, remains essentially North African in their roots. And the idea of trying to sort of stabilize those cultural tendencies has the capacity of essentially abandoning the possibility of cultural evolution, abandoning the possibility of universal citizenship, which is really essentially a sort of foundation of the concept of French Republican citizenship itself. And what we see then as a consequence is often a kind of binding of that subject, of the patient, as their ethnicity. And a failure to recognize the possibility of that patient's cultural evolution or cultural adaptation or assimilation. Now, this is a problem because it has really deep historical roots. The idea that a patient's culture or that a person's culture is linked to their behavior, linked to their mind, is something that, believe it or not, is not necessarily a new problem at all, but instead dates to the 18th century. And here I'm just going to take a very quick detour through some of the ideas that I outlined in my book, Colonial Madness, which came out about 15 years ago at this point, but I think which still holds up to some extent anyway. So I want to just kind of look at a sort of history of how culture and psychopathology have been almost inextricably linked from the very foundation of psychiatric practice, of the emergence of modern psychiatry. So this is a story that begins with Philippe Pinel, a psychiatric practitioner in 18th century Paris, who rose to prominence in the course of the French Revolution, and he's widely recognized as the founder of modern psychiatry. Here's an image of him freeing the so-called insane at the Froedtert Hospital, where these women were bound in chains, and he unleashed them, arguing that how can one free the spirit if the body is in chains? So he's widely recognized as a kind of liberator, and there's a sort of liberatory tradition in the founding of modern psychiatry. He himself carefully read the philosopher Jean-Jacques Rousseau, who argued that insanity or mental illness is a kind of byproduct of the civilizing process, that true nobility of spirit exists in our natural state, and that social progress, the sort of evolution of civilization, was essentially corrupting. It would corrupt our mind, would corrupt our spirit. Pinel adapted this in his work on aliénation mentale. This is where the term alienist comes from. He replaces the term, I know Dr. Shaw had mentioned earlier that language matters. I couldn't agree more. The French colloquial term for madness was folie, which translates loosely to madness or insanity, links to the English word folly. He replaces this with aliénation, or alienation, which is the loss of one's true nature, an alienation away from one's true psychic self, one's true psychic nature. And he argued that a greater predisposition to this kind of aliénation mentale would be a price that Europeans paid for living in advanced civilization. And the corollary here is that the so-called primitive subject, population, I'm sort of doing that in air quotes, this is their term, not mine, but people who lived in, again, air quotes, less civilized cultures had less of a predisposition to mental illness. And this becomes really psychiatric orthodoxy for about 40 years. The person who turns this on his head is a student of one of Pinel's students, a guy named Jacques-Joseph Moreau de Tours, who writes a book, a thesis about the use of hashish in North Africa. Essentially, he spent a couple of years traveling around North Africa, as best I can tell, getting high and writing about the experience. And one of the things he argues is that, indeed, there is this pervasive notion that quote unquote less civilized cultures have less predisposition to mental illness, But he argued that's because we tend to define mental illness as someone standing out within their culture as deviant, as pathological. And he simplified this story by arguing that indeed, based on his experience in traveling around Algeria, Tunisia, Libya, and Egypt, is that North Africa is itself a pathological culture. He taps into Orientalist tropes here, such as Eugène Delacroix's painting of the fanatics of Tangier, to argue that indeed this entire culture is functionally deviant, that the entire culture is pathological. And this notion really takes hold. Now, notice this is happening this is after 1830, when France first begins its conquest of Algeria. Algeria becomes a French colony in 1848. Tunisia becomes a French colony in 1881, Morocco in 1912. This process of a kind of progressive annexation of much of North Africa is accompanied by an increasing notion, a kind of scientific notion of the pathology of the cultures within those spaces. Kind of handy if you want to rationalize dominating another culture, to argue that this is a culture that simply cannot take care of itself. And that indeed, I'm just going to skip a couple of slides in the interest of time here. That indeed is something that plays out very clearly as not only the French, but the British and the Dutch begin to establish colonial institutions for managing mental illness. These are places that are segregated facilities, and as I examine in the book, I look at 6 of these psychiatric facilities in French North Africa, 1 in Morocco, 1 in Tunisia, and 4 in Algeria, that are founded beginning in 1934. Is the kinds of research that's produced here is very much in line with this idea of North Africans as belonging to an essentially pathological culture, an irremediable culture, with a gulf between Europeans and North African Muslims that is simply unbridgeable in a psychic sense. And the research that they produce very much fixes culture and mental capacity and mental illness very, very closely together. The works by the so-called Algiers School of French Psychiatry appear in some of the best French medical journals. These are not obscure publications at all. Beginning on the bottom right, Note de Psychiatrie Musulmane by Dr. Antoine Porot establishes what he argues is a racial hierarchy, placing people of French birth and French descent on top, and then gradually working its way down and positioning North African Muslims on the bottom of a psychiatric hierarchy that is as highly predisposed to mental illness, as essentially belonging to a pathological culture, as being psychologically not very resilient, and basically exhibiting pathological tendencies. And those pathological tendencies include a predisposition toward, as we see in the titles even of these other publications, primitivism, which they argued was fixed in the very cortex of the North African Muslim, or criminal impulsivity, or criminality and delinquency, essentially arguing that the North African Muslim was a born criminal who was essentially irredeemable. These, again, are not obscure kinds of publications at all, but instead were things that were that appear in what is essentially a kind of predecessor to the French version of DSM, the Manuel alphabétique de psychiatrie, which is edited by many of these practitioners, by Antoine Porot and a number of his students, which remains available. You can buy it in a Parisian bookstore, a medical bookstore today. It's in its, I think, 9th edition, something like that. Still with a number of entries that are just truly shocking about psychopathological tendencies in different cultures. It's been edited heavily. It's not quite as brutal as it was when it first appeared, but indeed much of this language remains intact. It's not just the theory, it was the practice of these colonial institutions that exhibits just a sheer brutality. For example, when electroconvulsive therapy comes online beginning in the late 1930s and early 1940s, we see efforts to experiment with it. And I've got data from French institutions on the left, a psychiatric hospital in Neuilly, as well as one in Paris, conducted experiments on patients. And what you can see is they experimented on very few patients, and they gave those patients relatively few treatments. In Algeria and Tunisia, what we see is a dramatic increase in the numbers of patients subjected to ECT, and indeed, most significantly, a dramatic increase in the number of treatments those patients were subjected to. And indeed, without getting into too many details, because it's just too awful to contemplate, in Tunisia in particular, experiments on indigenous patients included efforts to see exactly how many ECT treatments it took for a pregnant woman to abort, exactly to what extent you could perform ECT on patients with heart conditions. Just absolutely brutal experimentation. This is a profound contrast with the ways in which North African Muslims, or at least many of them, understand mental illness, understand treatment for mental illness, and the kinds of rituals and practices that surround the treatment of mental illness, as well as somatic illness in North African Islam. Typically, what one would do would be to visit Mrabit or Marabout in the kind of French transliteration, essentially a kind of holy man, someone who would typically set up shop near the tomb of a Muslim saint, and they would prescribe incantations or different kinds of rituals of healing. They might inscribe Quranic verses as a kind of talisman. Here you see an example of one that might have been prescribed for fever in 1908. And what they essentially do is they try to get the patient to make amends with an offending jinn or junoon, essentially spirits, that they see as the root of the illness. And to pay for the Mrabit's services, you'd pay with a chicken or a goat or an animal to sacrifice. What's critical to recognize is that these are non-invasive practices, right? This is nothing like ECT. This is nothing like psychosurgery, which goes into widespread use in Algeria in particular, beginning in about 1945. Another example, this one is local in rural Morocco, is called the Hadra, which is a kind of trance therapy. Here you see a woman who is kind of whirling her head around in the center of the frame of the photograph. She is being surrounded by musicians who are chanting and singing, and she's dancing until she enters, dancing wildly, until she enters a kind of trance. This is a woman who's suffering from symptoms of what we would call schizophrenia. What happens is the whole village comes out, and this band of traveling musicians goes from village to village, and they will treat patients with this trance therapy. As the patient comes out of the trance, the entire village sits down and collectively tries to find a place in the community where the patient's symptoms, where the patient's behaviors will not interfere with their social interaction. So essentially, it's an effort to try to socially rehabilitate the patient by adapting the community to the patient's needs. Again, a very stark contrast with what we see going on in these French colonial hospitals in the same period. Okay, so that was a kind of long historical excursion. Forgive me for the tangent, but I do think it's kind of relevant to the ways in which we look at the pandemic and global mental health. So what I want to argue here is, and I'll come back to the historical stuff in just a moment, but when we look at the COVID-19 pandemic and its impact on global mental health, let's go back to that, one of those early slides, right? This triple global public mental health challenge, preventing increased mental disorders as a function of the pandemic, protecting people with mental disorders from COVID-19, given that increased vulnerability, and protecting the mental health of health workers. And let's look at this not in a European or American context, but let's look at this in the context in particular of lower to middle income countries. Here we've seen extreme cases of anxiety and depression. We've seen trauma as it relates to lockdowns. We've seen trauma as it relates to school closures. We've seen trauma relating to pressure on health systems and unemployment. Now, again, I could be talking about the United States here, right? I could be talking about Western Europe here. All of these things have characterized our response to the pandemic, our psychological responses to the pandemic. But as a piece in Lancet Psychiatry pointed out in 2021, there are really particular challenges in countries that have weak or absent social safety nets and inadequate resources for managing these crises. So let's take anxiety and depression first. A 2020 study toward the beginning of the pandemic, it was an online survey in Bangladesh, surveyed 10,000 participants. 33% of them reported depression as a function of COVID restrictions, and 5% of them reported suicidal ideation. These are shockingly high numbers. If we look at lockdowns in lower and middle income countries, well, lower and middle income countries have a much higher proportion of workers in the informal economy. The informal economy, this is not an illicit economy. I'm not talking about drug dealers or sex trafficking or anything like that here. That's what we would call an illegal or illicit economy. The informal economy, rather, is when people do perfectly legal things, but in a very off-book kind of way. A good example of an informal economy in the United States might be babysitting. Where very few babysitters are, declaring their income and paying taxes on it. We don't typically 1099 our babysitters at the end of the year, and so on. So that would be an example of something where you're basically just hiring a teenager or hiring someone and paying them cash under the table, or now I guess Venmo becoming increasingly popular. But really, this is an informal economic relationship. Other informal economic relationships can include things like domestic service, and this is particularly characteristic of lower and middle income countries, where lots of workers, and especially women, are working in that informal economy, working in domestic service, doing lawn maintenance, doing construction work, but essentially doing this work for cash, completely off book. And what happens in an informal economy is you've got workers who have absolutely no unemployment insurance and who are typically working for lower wages than they might work otherwise, and they're working with very limited savings. So they essentially have little personal or individual ability to offset economic losses. Moreover, lower and middle income countries themselves have little ability to help offset those economic losses. So for example, we all remember the checks that we might have received in the course of the pandemic for a few $1,000s here and there. My colleagues in Europe had much higher aid than that. But in lower and middle income countries, that simply doesn't exist, right? That's simply not available. So this puts extreme pressure on people to work despite lockdowns. And that has led to significant resistance in many contexts, as well as street violence. And of course, all of this has brought with it added stresses that can lead to mental illnesses. School closures. There has been, of course, major attention to school closures and its effect on children's mental health in the United States, of course. But one of the things we have to think about is schools, kind of never really closed here, right? They closed for a couple of weeks, and then most of our schools went to online education, remote schooling. In many developing countries, that's simply not a possibility. And so school closures have stretched now to up to 2.5 years in some locations with no remote schooling. This is the case, for example, in much of Uganda. Students are losing serious academic and social benefits, but they're also losing some really important protections. I know we talk about the loss of academic and social benefits with remote schooling and psychological pressures that puts on American children, and I don't want to minimize those. But one thing that's happening in lower and middle income countries is lost protection from labor exploitation. If these children aren't in school, they are subject to working in sweatshops, for example. Lost protection from child abuse, where teachers are often, just as in the United States, are often the first to notice incidents of child abuse. For girls in particular, lost protection from early marriage and pregnancy. And for all children, lost protection from food insecurity, because many children only receive sufficient food in their school contexts. So these are, again, some of these issues are present in the United States or in Western Europe. But indeed, lower and middle income countries, we see really extreme challenges linked to school closures. Let me turn now to what I want to call, and I'm beginning to wrap up, I promise, a series of confounding crises or cascading crises that we see happening as a function of the globalization of the COVID-19 pandemic and its mental health sequelae. I want to go back to the slide from Bob Desjarlais and the World Mental Health Report. Again, we see as improvements in global public health and life expectancy are boosting population. Well, early marriage and early pregnancy is also going to boost population. So what we see is an exacerbation of that problem. So that means even more people are now going to be living into the age of risk for these disorders. COVID-19 has led to a real exacerbation of the problem of violence and poverty, increasing drug and alcohol abuse, and economic exploitation. All of these things are getting worse as a function of the pandemic. And of course, in developing countries, those resources which were already scarce for treating and containing mental disorder are now, of course, stretched even further as a function of the health needs of the pandemic. And of course, we still live in a globalized world as people are starting to travel again. And so that means all of these human and financial costs are going to be shared by all of us. So I just want to emphasize the ways in which COVID-19 and its mental health consequences are exacerbating all of these pre-existing issues, all of these pre-existing crises. Indeed, one thing, and this is to go back now to our to that historical excursion that we took, that tangent I went off on. As migration has become a critical aspect of globalization, we also need to recognize the way in which we have to sort of disentangle some of these crises. If we look at the experiences of migrant communities, and a colleague of mine, Tanya Lerman, has done a wonderful book. It's an edited volume on basically migration and mental illness. One of the chapters in this book points out the experiences of migrant women in particular, West Indian women in particular in London, who moved to London for increased economic opportunity, but that economic opportunity comes at a real cost. It comes at a cost of suffering from intense racism. It comes at a cost of suffering from social inequality, and it comes at a cost of real social fragmentation. And indeed, one thing that's happening is, as a function of racism and social inequality, many patients are just crumbling under that stress and presenting with very high rates of mental illness, including anxiety and depression. And this is common not just in London, but in Europe and the United States. And one of the critical issues that's happening, to get back to that historical data I shared, is the danger that psychiatrists can make about the danger of the assumptions that psychiatrists can make about culture and race. To argue that an increased tendency toward these conditions is simply part of the culture of West Indian women in London, rather than a response to structural conditions that place them in high stress situations. Where this kind of differential diagnosis problem can emerge, there's a fantastic study done by a couple of sociologists named Loring and Powell in 1988, which points to the dangers of implicit bias in psychiatric diagnosis. Essentially, what Loring and Powell did was they surveyed a couple of hundred psychiatrists, and they sent them a series of diagnostic criteria, basically a series of symptoms. This was a written description of a patient. And they would attach markers of race and sex to these patients. So, for example, they listed a number of symptoms, and then they would say, okay, and this is a Black male, age 45. Or they would say, this is a white woman, age 60. Almost invariably, the psychiatrists who responded to the survey described the Black male as suffering from schizophrenia and described the white woman as suffering from depression. Same symptoms, right? Same exact symptoms. And I think we all know from looking at DSM, there's very little overlap in the diagnostic criteria for those two disorders. And fascinatingly, in cases where they didn't include race or sex, the psychiatrist said, oh, there's not enough information to make a diagnosis based on this written description. Now, I hope that we've come somewhere since 1988, right? This is 30 years ago. I hope that we've evolved since then, but it is an important study for thinking about the ways in which a patient's appearance, a patient's culture can certainly constitute some information that goes into a diagnosis. And that's why I think we need to guard against those kinds of tendencies that have such a long and pervasive history in Western psychiatry. There may be cause for hope here as well as we look at mental health response to the increased stresses of the pandemic. For example, the NGO Partners in Health, Compañeros en Salud in Mexico, has a shop in Chiapas in Mexico, where they've employed a range of health workers to develop a new model for mental health care. What they've done is they've used limited funding to basically provide for a team of women mental health care workers, as well as lay staff, to offer treatment to patients, but also in the case of those lay staff in particular, who are very inexpensive to hire, to provide accompaniment, to provide food, and to provide transportation to patients who need access to specialized services. Essentially, what the group does is they act as intermediaries between vulnerable communities and the state to help secure resources, which are limited. But what the NGO has done is essentially bridged the gap between those limited resources and made them accessible to the community. They've done this based on a model for treating tuberculosis in Haiti, which the group has done since 1984 or so, and which has been highly successful there. Other examples, a study in Lancet Psychiatry, again, one I referred to earlier, looks at a whole range of different interventions in low and middle income countries. Don't expect people to read all of this, but essentially what they've done is used telemedicine to try to reach people who were previously inaccessible or who previously found mental health services to be unobtainable. For example, in low and middle income countries, what we see is really high rates of mobile phone use, much higher than in the United States and Western Europe. Basically, these are places where landlines have never existed. And there's a kind of leapfrogging technology where as mobile phones become available, people adopted those technologies very early because they were a little bit more accessible, given the infrastructural challenges of building landlines in a developing country. This has created possibilities for treatment, but also possibilities for training and education. So training up staff, especially lay staff, in the real basics of treating mental illness and providing those, basically trying to enhance accessibility, has done a great deal to use those technologies to find a real opportunity for treating mental illness. These are limited examples and this is very limited cause for hope. But I did want to end on something of an optimistic note in any event. So in conclusion, the kind of mental health impact of the pandemic is absolutely overwhelming, especially in lower and middle income countries. The pandemic mental health crisis is exacerbating all kinds of existing crisis states in many lower and middle income countries. Those sites really have very few resources to cope with those crises. Psychiatry's history of intervention across culture is not terribly encouraging, but at the same time, there are some really encouraging models that are emerging from NGOs as well as in telemedicine. So with that, I will say thank you very much for your attention, and I will stop sharing my screen. Thank you very much. And I'm happy to take questions with whatever time we might have.
Dr. Keller, we have a question from Jessica. What does ECT stand for again?
Sure. Thanks, Jessica. I appreciate the question, and thanks to those of you. You're welcome to those of you who have said thanks. Very kind words. ECT is electroconvulsive therapy, more commonly known as electroshock therapy. This was developed by an Italian psychiatrist in the 1930s and goes into absolutely widespread use in Europe and North America in the course of the 1940s or so. It's a treatment that still exists for treating. It was originally used extensively on schizophrenia, patients suffering from schizophrenia. And it was based in this really a kind of crazy notion that psychiatrists and neurologists never witnessed epilepsy and schizophrenia in the same patients. And so they started making assumptions that, oh, well, maybe there's some kind of protective value of the seizures that patients suffer when they have epilepsy that guards against schizophrenia. This is a classic example of correlation not necessarily equaling causation, right? And so they thought, well, maybe if we can find another way to induce seizures in patients, we can sort of stave off some of the effects of schizophrenia. As it turns out, it's pretty ineffective for treating schizophrenia, but remains kind of effective in really intractable cases of depression where patients are unresponsive to SSRIs or psychotherapy and other kinds of treatment. So it is something that remains in use. It's been greatly refined since its use in the 1940s, when at the very beginning, psychiatrists were basically putting bare wires across people's temples and flipping a switch on the wall. Now patients are anesthetized. They're given a kind of anticonvulsant drug to prevent the body from convulsing violently. Patients used to convulse so violently that they would break bones. That's not happening anymore. And again, it's used very rarely, but it was an incredibly widespread use in the middle of the 20th century. Looks like another question from Amber. I think another contributing factor could also be lack of support from
another
religious
question from
organizations.
Amber. Do you think another contributing factor could also be lack of support from religious organizations?
I think it could certainly be a factor. One of the things that we've seen in the course of the 20th century and well into the 21st century is that religious organizations have been absolutely essential assistance to the state in providing care, and indeed much mental health care in particular before the advent of the quote-unquote asylum in the middle of the 19th century were church organizations, right? Were Christian organizations in particular. At present, certainly religious NGOs, missionary organizations have the capacity to help states that have a lack of resources. Those organizations often have an agenda as well. And so that help can be kind of a mixed bag. But great question. Any other questions, or otherwise I'm happy to yield back my time, as they say.
All right, Dr.
Yes,
Keller.
people are welcome to email me if they have any questions. I'll put my email in the chat.
All right. Thank you very much for speaking today.
Thank you for having me. I very much appreciate the invitation.
So thank you very much. All of us at the National Association of Health Unit Coordinators and Froedtert appreciate you sharing your information with us today. So we're going to take a 10-minute break, stretch, refill your water, and we'll be right back.
This is home for me, man, and a lot of memories, a lot of friends, a lot of family, and it's just a blessing to be back here to see Columbus grow in such a way.
Well, if you like seeing classic rare cars, drinking a cup of joe, and supporting a good cause, well, you're in luck. The Cars and Coffee Rally in support of mental health awareness is making its way to Columbus. It's hosted by Cleveland Browns offensive tackle Chris Hubbard. He joins us now to tell us all about it.
I was so excited to hear about Chris Hubbard coming to town because, people know who he is. He's kind of like a hometown hero. He went to Carver High School. And the fact that he's brave enough to talk about such a taboo subject as mental illness, that's even greater. I think there are a lot more ears that listen. It's like, wow, you came from here and you're struggling with a mental illness, but you're successful and you're thriving, so I can do well. And students and the community in general, they tend to listen to stuff like that.
Just seeing the high school the way it is now, it's emotional because you've seen how much it has grown. Bro, this is way better than what we had at all. Way better. No, man, we had none of this. None of this. We were told that if you're going through something, You might want to push through it. Nothing's wrong with you. Be a man. And we never realize it until we get to this deep point in life to where we're like, man, something is going on wrong with me. Another note, man, I want y'all to know about mental health too, man. Mental health is serious, man. Whatever, like, if you're dealing with like anything as far as like depression or anxiety or anything like that in your life, like mental health, like I've been through it myself, because football like really wears on you, man. It really does. Like it takes you away from your family most of all, and then as well as like you putting your body on the line too. So every day you come to work, man, you got to deal with these hostile environments, going through different stages in life. You might be dealing with depression or anxiety, but I had to get some help.
It really touched his heart to be able to go back and have that opportunity to kind of let these young men know, hey, listen, I'm just like you. I saw how it's important to him to break down that stigma, especially in the African-American community, especially African-American males, on how we're just supposed to hold everything up and just suck it up. That's that old school mentality where it actually builds up inside and it creates a lot of stress, which then in turns into the depression.
Take care of yourself. Talk to somebody if you're going through it, a counselor, anything, because like you might not know you're going through it, but at that time I was like, man, I'm a dude, man, I'm a man, like I can deal with it myself. But at the same time, I was losing weight. I was 305, I lost weight in like a month, bro. Like I went down to like 275. So I had to get all my weight back from dealing with stress and anxiety and going through the different roles and depression and stuff like that.
You can see on a daily basis the issues that we have to deal with in regards to mental health. And for him to take on that issue, it means a great deal to us.
Seeing the young students here today at Carver Columbus High School, I saw myself sitting in one of those seats. And just to be able to talk among those guys brought me back a lot of memories of how I was in school and how I dealt with a lot of things going on.
We hear about bullying, we hear about peer pressure, we hear about problems with people being bullied because of their sexuality.
Just seeing my friend grow through that, yeah, it was pretty tough. He liked other men, so that's kind of why they picked on him, because of what he went through. But he dealt with a lot of things at home as well too. It's not just as far as bullying at school, but he dealt with everything at home. Like I used to talk to him and try to figure out what's going on, but you know, he was just so sheltered into the fact that, you know, he wasn't gonna let that come out. He was always holding something behind and just keeping it to himself. And then next thing you know, that suicide happened. So.
In my experience, talking to African-American youth, it's just overcoming that stigma. Whereas, you know, maybe their parents may not necessarily believe or understand what mental illness is. They kind of get it and they want to get help, but they don't really know who to talk to about getting help and where to go to get help.
He opened my eyes to a lot of it. Now I understand it's not, like I said, somebody's crazy.
Oh,
you
no.
know, that's the first thing.
No,
Oh, she's
no.
mental.
Yeah.
That's what you think.
Right.
That's what my thought process was a long time ago. But when he started, it's like, oh, wow, it just brought more awareness to me. Really did. It helped me to understand more.
And so where will the proceeds go?
The proceeds will go to NAMI. Everything that we're raising will go straight to them. And we just want to see it happen and raise as much as possible.
Great. Chris, thank you so much for being here.
Thank you guys for having me.
Yes, the Cars and Coffee Rally. We hope everybody will come out and support mental health.
I'm hyped to be here, man. I'm excited to be here. Man, this is what it's all about, man.
We were out there 6:30 in the morning. The NAMI crew came through. We set up the table. Everybody started popping their hoods, getting the music going. Chris was in heaven.
Yeah, man.
We got the jerseys.
We had a great day in regards to fundraising and people supporting the event.
Appreciate what you're doing.
Yes, sir, man. I'm glad you brought the rise out here, man. You know, we're just trying to raise that awareness for mental health and just have a good time as well.
You know, it takes a brave man to really, especially a football player, an NFL player, to come out and kind of admit to having mental illness issues and most importantly, finding help for it. And there's a lot of them out there that have these issues. And I'm very proud of Chris being brave enough to really shed light on it, but then also tell his personal story about that.
I got you, bro. I got you. Come on, look at the camera, look.
Anyone that's dealing with mental health today, just know your voice is always meant to be heard. You're not alone in this world. There's a million people that's going through the same thing you may be going through. And there's many ways and different things that you can do in your life that can help you get out of that depression, that hole that you may be in. Just know that we are here to help you, and NAMI is gonna continue to help as much as possible.
What we need is your voice, your engagement, your participation, your spreading the word about the important work that you do. Continue being the valued team member that you are in healthcare. And as I said, be the voice, get involved, participate. We need every health unit coordinator, regardless of their title. We need every person in that role to be part of the association and to just spread the word about, what an awesome group we are.
Zoe Schmidt is a licensed clinical social worker who specializes in working with adult mental health and addiction. She has been working in this field since 2015, where she initially worked as a substance abuse counselor before she later went back for her master's in social work at UW-Milwaukee. She has worked in various settings, including outpatient medication-assisted treatment, intensive outpatient programming, county jail systems, and is currently employed at Froedtert Emergency Department. She enjoys working with trauma, acute psychiatric crisis, and helping serve the underserved population. In her free time, she spends her time engaging in outdoor activities such as rock climbing, kayaking, hiking, and enjoys spending time with her family, friends, pup, and hedgehog. Ashley Thousand is a licensed clinical social worker who specializes in substance use disorders and mental illness in adult populations. She first began working in tobacco cessation treatment in 2013 while going to school to complete her BA in psychology and then master's in social work. Since that time, she has worked in multiple settings, including partial hospitalization and intensive outpatient programs, outpatient opiate maintenance treatment, and Froedtert Hospital's emergency department. She currently works with the inpatient psychiatry team as the AODA psychotherapist at Froedtert Hospital. She has a specialty in opiate use disorder, crisis intervention, and fighting the stigma around mental illness and addiction. When not at work, Ashley enjoys traveling and spending time with her husband, family, and 2 pugs. Please welcome Zoe Schmidt and Ashley Thousand.
Hi, good morning, everybody. Can everyone hear me okay? Can I just get a thumbs up if so? Chris, can you hear us? Wonderful. Sounds good. All right. To get to sharing the screen. Okay, so I'll be doing the first half of the presentation. I'm Zoe. Today, Ashley and myself will be addressing the mental health and addiction side of things, and we're going to talk about kind of accessibility and barriers to treatment for both mental health and addiction. We are based in Wisconsin, and I know that we are nationwide, as well as we have a couple people from the international side of things. So as we go through, this is going to be pretty heavily focused on Wisconsin. So during parts of it, I will just encourage you to continue to expand your knowledge outside of this presentation to the specifics in your county and or state. So just wanted to give that information before we get started, just to keep that in mind. So today we will be talking about the adult population. We only have an hour, so we did choose to focus on the adult population. This does not pertain to all children as well. So like I said, adult population in Wisconsin. We'll talk about voluntary and involuntary mental health treatment, different levels of care for treatment, some financial considerations to keep in mind, what are some government-based interventions, and then what are some barriers to treatment and access to care. So to get started, when we look at treatment, we want to always explore voluntary treatment for people prior to any other type of treatment, such as involuntary, which we'll get into. The benefits to voluntary treatment, it decreases coercion, so it doesn't interrupt the stages of change. There's findings that show people have to pretty much be ready to change, ready to put in the work for there to be successful treatment outcomes. It increases patients' treatment satisfaction. It increases compliance with the treatment, decreases hospitalization readmissions. People are more likely to put in the work and actively engage in treatment and try to make those changes when they're not being forced into treatment and they actually want to be there. Voluntary treatment also is a trauma-informed care approach. It can be very traumatic for people to have to be forced into treatment if it's not something that they want to be doing. It can also trigger some historical traumatic events for people. So like I said, we always want to try to explore voluntary treatment for people struggling with mental health and addiction prior to going to an involuntary treatment route, which we will get into. So for anyone who is voluntary for treatment, they have to be able to consent to treatment. So everybody will fill out an informed consent. If a patient cannot, so sometimes people have what we call healthcare power of attorneys. If those are activated, they cannot sign someone into psychiatric or addiction treatment. The patient must be able to comprehend what it means to go into treatment, as well as be able to consent on their own. Some people have guardianship, which is a legal process that deems a person to be incapacitated. This could be a result of a developmental disability, persistent and serious mental illness, degenerative brain disorders. This is actually a process that is a decision made by the court of law. So if somebody does have a guardian, the guardian must consent to treatment, as well as the patient must assent to treatment. So there has to be two consenting people. This goes back to mental health laws, insane asylums, formerly known as, when family members just didn't want to deal with maybe their wife or a child, and they would just sign people into institutions, and then that patient was kind of stuck there. They didn't really have rights. They couldn't get out. So it has now shifted to a patient also has to be able to assent to that treatment, so that we can still honor their rights. Informed consent is not something that is required if we have to have somebody go to involuntary treatment because they're not consenting. So this is only needed for those who are voluntary. So moving into getting treatment for involuntary treatment, There's definitely a lot of ethics surrounding this because people do have the right to refuse psychiatric care. We always want to honor people's autonomy. We want to respect the patient's self-determinations. They have the controls over their life. They have the right to make poor choices. We have to allow for people to we have to honor their rights as a human being. However, people do have the right to receive life or limb-saving treatment against their will when their mental health is impairing that judgment. So mental health laws for involuntary treatment, they've been written so that we can help kind of find a balance between both of these conflicting rights. So when we're looking at this balance, we want to make sure that their autonomy is being honored, their beneficence. Are we providing the best recommendation with the patient's best interest in mind? Non-maleficence, we want to do no harm to the patient. So we're weighing in, is this going to be more helpful or is this going to be more harmful? Fidelity, ensuring that statements with patient are truthful and accurate. Are they telling us that they'll go to voluntary treatment? Can we believe this? Justice, are we advocating for the patient's well-being during this process? And veracity, you know, are we providing the truth of the matter during our encounter based on kind of what we're seeing for the patient? And we'll go into kind of what that involuntary treatment looks like to see, yeah, are they providing the truth of the matter? Okay. So involuntary treatment, this is going to look different from county to county as well as state to state and internationally. Please familiarize yourself with your laws in your county as well as in your states. So involuntary treatment, also known as Chapter 115, emergency detention, mental health hold, commitment stipulations, those type of things. It's going to vary from state to state. So specifically in Wisconsin in 1976, there was a Mental Health Act. Wisconsin legislature codified greater safeguards in civil commitments. So one thing that qualified for them for someone to go under involuntary treatment is, are they a harm to themselves? Are they a harm to other people's? And did they have impaired judgment with probability of injury to self or physical impairment? They continued on and they made some amendments to this Mental Health Act, where they also added in the inability to care for the self, as well as commitment based upon risk of decompensation. So these are people, maybe they have major depressive disorder and they have just stopped engaging in their daily activities. They're decompensating. Their house is like full of garbage. It's not habitable at this point. So that was then also added into criteria for the involuntary treatment. When we look at what is the appropriateness of involuntary treatment, one thing that's super crucial is a person has to have a treatable mental illness. People can have intellectual developmental disabilities who are placed on holds. However, sometimes people have situations where they have gone inpatient time and time again. It's never been shown to be helpful because it's the underlying cause is not a treatable psychiatric illness. So imperative that a patient has a treatable mental health illness, that a person is identifying and demonstrating dangerousness to self or to others, and that if a person is being uncooperative and is refusing voluntary care, we always want to make sure that we're honoring the least restrictive means. So if somebody is showing to be dangerous to themselves or to others, but they are willing to go voluntary for treatment, a lot of time you'll see that these holds are not being placed. So in Wisconsin, who can place an emergency detention? This varies greatly from state to state. So again, please familiarize yourself with this. Here in Wisconsin, we have the main people who are placing them are going to actually be our police officers, our sheriffs, police officers. Then we have treatment director and treatment designees. The treatment director and designees, this is defined as a doctor, psychiatrist, or a psychologist who is authorized through the county to place a treatment director supplement, which we'll go into what that means. And then also doctors, solely in the case of solely in the case where they're operating in an inpatient psychiatric treatment for voluntary patients, they can place what's called a treatment director affidavit, which we'll also talk about what that means. So currently, these are the only people who can place them in Wisconsin. Again, it varies greatly. It varies greatly upon state to state. So please just know who in your county can place these holds for people. So what are the steps of involuntary process? So in the state of Wisconsin, law enforcement initiates that emergency detention, which in Milwaukee is good for 24 hours, and in all the other counties is good for 72 hours. Most states across the board do take that 70-hour approach. So then what happens is a county psychiatrist or psychologist determines if a patient is in need of voluntary treatment. So they do the assessment. Do they have a treatable mental health diagnosis? Do they have imminent danger to self or to others? Are they involuntary? So if they are deemed that they do not need involuntary treatment, the emergency detention is released, and then they develop a discharge plan. And then if they deem that they do need involuntary treatment, they will complete a separate legal document. These are the treatment director's supplement and the treatment director affidavit. So that is what I was referring to in the previous slide. So the treatment director supplement, also known as a TDS, this is a separate legal document that extends the emergency detention from 24 hours to 72 hours. This affirms that the patient does have that treatable mental illness. It does include a provisional diagnosis, and that the patient is deemed to be imminent danger to self or to others. Once they have that TDS placed, then there's a probable cause hearing, which must be completed within 72 hours. This just looks to see, was there probable cause for this emergency detention to be placed? Are we doing, are we doing right by the patient by having them on this involuntary hold to help treat them and keep them safe? Okay. All right. So, oops. So I'm not going to go over this in depth. I just wanted to show you in a flow sheet kind of all the steps that can go into involuntary treatment. Again, please familiarize yourself with your county and or state. So this is a treatment director supplement has been placed. Sometimes people get stipulations where they end up having, the stipulations is when they're going to be meeting with a treatment team and coming up with different treatment engagement that can be put in place. This is not legally binding. It's just, recommendations as to what you should be engaging in. They could potentially be discharged. They could also have a final commitment. Final commitments are legally binded. They typically last between 6 to 12 months. This can be anything of like they have to engage in treatment as recommended by psychiatrists. So maybe they start at a high level of care and work their way down lower levels of care throughout the 6 to 12 months. But this one is legally binding, and they can actually be redetained for treatment if they are not following up with their commitment order. And then with some of these, there can be a medication petition that is associated with them. This is just saying that they have to take their medications as part of their treatment. Obviously, because sometimes if people are not taking their medications, it can greatly influence their psychiatric presentation. So again, please familiarize yourself with how this works for from county to state for you all, because it will look a little bit different for everybody. Then we have, so now we've gone over the process of being placed on an emergency detention through the Chapter 51 process or the involuntary treatment process. Another way to get somebody into involuntary treatment is through what we call third-party petitions. So maybe somebody gets called to a scene, but the patient is not demonstrating that they're immediate risk to, or imminent danger to self or to others. But family or friends swear up and down that this person is not doing well. They need treatment. They're not willing to get treatment. So this is another option that people can take. 3 individuals who know the patient, they allege that the patient has a mental illness, needs treatment, and is dangerous as a result of their mental health. These 3 people have to have witnessed behaviors demonstrated by the patient within the last 60 days leading up to the petition. What they do is they go through and they write down all the concerning facts. It usually has to be dated, time-stamped as to when these events occurred. The 3 people then have to be willing to testify in the court of law. They bring their findings to the judge, and then the judge will deem if this person, if the third-party petition is approved or if it has been declined. This process is always initiated through Office of Corporation Counsel. So that's pretty standard, but again, familiarize yourself with your state or county. If somebody does end up having a third-party petition approved, they can then put out a order for that person to then be picked up and taken into treatment. All right. Oops. So now we're going to talk about what are the different treatment levels of care. This applies to both mental health and to addiction. So we'll talk about outpatient, intensive outpatient programming, partial hospitalization programming, inpatient treatment, and then residential level of care. So outpatient programming, this is individual psychotherapy. Sessions typically go from 45 to 60 minutes. It's up to the patient and the therapist to determine appropriate frequency for being met with. Typically, people start on a weekly basis and then they get lesser and lesser as they progress in their treatment. So it can be on a weekly basis, bi-weekly basis, monthly, or even just check-ins as needed. On average, there is charges of between $65 to $250. Some therapists, psychiatrists, psychologists include sliding scales, which means based on a patient's ability to pay, they will alter what they pay per hour. Insurance can cover, and then there's also some who just take out of pocket, no insurance included. So that's for outpatient programming. Intensive outpatient programming. So this is going to be a group therapy. It's typically 1 therapist per 10 patients. These can be 3 to 5 days a week. They're typically about 3 hours a day. 3 to 7 weeks in length. It really depends on insurance. They look to see, is the patient progressing? Do they still need this high level of care? So that's reviewed weekly during the treatment process with the insurance people. During this, they get psychoeducation. They're learning about kind of, about their diagnosis, about coping mechanisms, about how to change their behaviors, and kind of what are their triggers, getting to kind of know themselves a little bit more intimately so they can be more successful moving forward in their treatment. They do meet with a psychiatrist weekly. During these times, they're getting evaluated for medications. This could be for mood management. This could be for helping cessation of substance use. During this, they typically have individual and family sessions that are offered to try to take a little bit more of a holistic approach and make sure needs are being met on several different levels. This typically is on average between $250 to $350 a day. The insurance is accepted. It accepts many insurances. Some people do have to pay out of pocket, which they would then have to sign an agreement that they're willing to pay out of pocket, given that it is a pretty hefty bill that people would have to pay. Some facilities do have grant funding, so patients are able to work with financial advisors at facilities and get some funding through those programs to help pay for their treatment. But those are specific qualifications that people have to meet to be reviewed for that. Then the step up from intensive outpatient is partial hospitalization programming. Again, this is going to be group therapy. It's going to be one therapist to every 10 patients. This is going to be 5 days a week, 6 hours a day. So it's like a full-time job for them for that next 3 to 7 weeks. Again, depends on insurance. Typically, people get stepped up to partial hospitalization if they're an intensive outpatient or outpatient and they're just not doing well. Maybe they're still using substances. Maybe they are still demonstrating significant mood instability. They'll get bumped up to this partial hospitalization. Again, they get psychoeducation during this process. They get group processing where each person goes through, individually gets checked in, and they can get feedback from other peers for that peer support. They get nursing groups where they're learning kind of about health, about sleep, about kind of the more medical side. And then they get some experiential therapy. So maybe they're playing games, maybe they're doing yoga, maybe they're doing team building exercises for communication. They get a little bit more robust engagement throughout the day than that of intensive outpatient. Again, they also have the weekly psychiatrist check-ins for medication management, as well as the individual and family therapy sessions. On average, this is about 300 to 400 per day. Then we have inpatient treatment. So the purpose of inpatient psychiatric treatment is to stabilize an individual who is experiencing an acute psychiatric condition. This is for people who are at a lower level of care, or they're not able to manage and keep themselves safe without being kind of on a locked unit. This can be for people who are actively suicidal, homicidal, demonstrating acute psychosis, mania, or if they're going through a medically significant withdrawal from like alcohol or benzodiazepines. Average length of stay in the US is between 3 to 12 days for inpatient treatment. So inpatient is going to be pretty restrictive. It is on a locked unit. No cell phones, laptops, iPads, or anything, because we want to honor the confidentiality of other patients while they're there, as well as have patients focusing on, getting better. They have same-sex shared rooms, accommodations available for people who have, maybe they have significant complex trauma that can be triggered by having a same-sex roommate. Maybe they have a CPAP machine and they need to have, accommodations there. So there are accommodations available, but typically they're sharing a room. They do have groups that are offered throughout the days in treatment, which are not mandatory, but are highly encouraged. A lot of times the treatment groups will be based on what is the main kind of concern amongst the patients. Maybe they have a very heavy addiction focused group of people inpatient. Maybe they have a very heavy caseload of depression, and they kind of gear their groups towards what is currently admitted to their unit. Patients are going to be seen by a psychiatrist daily, working for quick medication adjustments. And then patients meet with mental health professionals for treatment planning and for discharge planning. Inpatient state facilities are about $1,233 per day. Private can be anywhere between $1,200 to $2,000 per day. So again, it's a pretty hefty bill. Substance use treatment tends to be slightly more expensive than mental health treatment at this time. I don't necessarily know why that is, but it was found that they are slightly more expensive than mental health treatment. And then the last and highest level of care is going to be residential level of care. This one is going to be between $10,000 to $60,000 per month. This level of care is usually used after all other lower level of cares were exhausted and they just weren't shown to have much relief. So these are going to be a lot of times for eating disorders, for substance use, obsessive compulsive disorder, and just people who are really struggling to be at home in their normal day-to-day life and just really aren't able to get relief from those symptoms. The length of stay for this can be between 30 to 60 days. They do have 24-hour support and monitoring with mental health professionals and nursing professionals. The nice part about residential is it allows for patients to have structured schedule. They get to engage in activities. They're taken out of their potentially triggering environment at home. They have this supportive environment to help them work through kind of their concerns that they're experiencing at that time, which might not be able to be successfully obtained on the outside during those 30 to 90 days. And then it provides more frequent therapeutic contact and implement a wider span of therapeutic modalities. So residential can be extremely expensive. Definitely can get a little bit more pushback from insurances. Recently in Wisconsin, they started to offer more funding for residential level of care for substance use, which is really exciting news. And we hope to see more of that. Again, something that would be worth looking into for each state and county. So then we get into some of the financial considerations. I did just explain kind of the different levels of care for and how that focus or you know, how financial considerations are to be taken in account when we're looking at different levels of care, because as you saw, the higher you get up, the higher the amount gets. So when we look at reasons for not receiving mental health services, we have to acknowledge that some people cannot afford the costs. This was taken in 2020. So some people couldn't afford, some people didn't know where to go for services, concerns about being committed or having to take medicine. Some people, again, just are treatment resistant. They don't necessarily want to engage in treatment. They could handle their symptoms without treatment. And then insurance doesn't pay enough for mental health services. When we talk about barriers to treatment, this will be something that we address a little bit further. So this just is a little bit of a demonstration to go through kind of where each state stands in terms of what their cost for care is, how good of access to care they have, and what is the quality of the care. Okay, so the cost is going to be the uninsured rate, average out-of-pocket rate, what are the annual health insurance premiums, how much do they get charged for psychotherapy sessions, the access mental health providers per capita. Obviously, more metropolitan cities are going to have a lot more access to mental health than more rural areas. And then the kind of the quality, and this is going to be adults reporting any mental health in the past year, and kind of just their subjective report of how that treatment was for them. So this is just a good little demonstration. It just goes to show not the same across each state. So here in Wisconsin, we're towards the top in terms of you know, overall cost, access, and quality of care. So if you, I'll leave this up for a second if you just want to take a look for your state. All right. All right, and then just getting into some prevalent policies regarding mental health. Prior to 1996, health insurance had different coverage for physical health versus mental health and substance use. So in 1996, the Mental Health Parity Act was implemented, only required parity of annual and lifetime dollar limits to medical coverage. So there was not substance use coverage at this time. And then, so this was saying that they needed to be equal for both the medical as well as the mental health. And then the Emergency Economic Stabilization Act, also the Mental Health Parity and Addiction Equity Act of 2008. This went into effect just in 2010, which is still pretty recent. Applies to the group of health plans for 51 plus employees. This is where they required equal benefits for mental health, substance use, medical coverage. There was no requirement to provide mental health coverage, no requirement on what condition must be covered. But these were just some progressive stabilization acts that did allow for mental health to be considered a medical concern. So people weren't having to pay out of pocket for medical complaints and separately for mental health complaints, but instead it was all going to kind of the same deductible and medical plan. Wisconsin Mental Health and Substance Abuse Parity Act of 2010. This attempted to close smaller gaps on smaller businesses. Places were able to opt out if they had less than 10 employees. The Patient Protection and Affordable Care Act of 2010 requires the state-based health insurance exchanges to include mental health and substance use as an essential benefit and at parity to medical coverage. So we are getting more progressive, definitely. It allows for us to have more access to care as it's all kind of lumped into one versus keeping it separate from medical. As we know, Americans, medical costs can be significant at times. So just to go over some of the insurance side of things, Medicare is exempt from the parity legislation. Medicare has limitations on lifetime inpatient coverages. So if you are covered by Medicare, they only cover 190 days of inpatient mental health care treatment in one's lifetime. So if somebody were theoretically to go for 190 days straight to inpatient treatment, and then 3 years later, were struggling with similar mental health concerns and needed inpatient, those 190 days do not renew. Those 190 days are no longer at that patient's expense. Or they have to then pay out of pocket at that point. Medicare typically covers 80% coverage, with co-insurance covering another 20%. And then Medicare Improvements for Patient and Providers Act of 2008. This is when they only used to cover 50% outpatient mental health and substance use treatment compared to the 80% of medical. As of July 15, 2008, they do now cover 80% of the mental health side of things. So again, we are seeing a little bit more progression with mental health care coverage. All right, and then we have Medicaid. So federal law requires states to cover certain individuals, including low-income, qualified pregnant women, children, and individuals receiving Social Security. People have to be at poverty level per household. For 48 states and Districts of Columbia, the poverty level for one person is $13,590. So if you are at or below that, you can qualify. If there's more people to the households that are dependent, that amount does go up. So for 2 people, it'd be 18,310, so on and so forth. Those tables for what the poverty level is per, if there's 10 person in the household, those are easily found online. Around $280 billion was spent on mental health services in 2020. So that's about a quarter of that came from the Medicaid program. So some patients have straight Medicaid, they have straight state insurance, where others have managed care. So what managed care does is it helps to aims to manage costs of utilization and quality of care. So somebody could have straight state insurance, but then they could have a managed care Blue Cross Blue Shield, United Healthcare, Molina. Some people who have like medical complexities will have just straight state insurance because it helps cover better. However, that actually does cause for them to sometimes have less access to mental health care, which is unfortunate. Sometimes it can limit people to just straight hospital-based treatment versus private psychiatric treatment, such as somewhere like Rogers, Aurora Psychiatric, for people who are familiar with the Milwaukee area. So it does help having the managed care because it helps combat some of those high costs. However, it can be pretty limiting sometimes if they can't have those managed healthcare because not everywhere accepts just that straight Medicaid insurance. And then the other option too, if you don't have insurance through your place of employment or you're above poverty level or don't meet criteria for state insurance, there is the Affordable Care Act, which is Marketplace, also known as Obamacare. This has been with us since March 2010. Goal is to make healthcare more affordable and accessible to a wider range of people. However, on average, people who are paying on average $438 per month. So that's a pretty big bill for for this insurance, and they do have different packages. They have a bronze, silver, and gold. Plans do increase. Obviously, a bronze is going to be at a lower payment, and then the gold's going to be at a higher payment. Overall, marketplace is not the most friendly when it comes to mental health treatment, so you're paying a very high out-of-pocket per month, and not getting the best benefits, unfortunately, for mental health services. And then as people do get older, payment plans do increase with age for marketplace. And that is the end of my portion, so I will hand it over to Ashley to finish us out. Oops.
Hi, I'm Ashley Thousand. So I'm going to be talking about federal and state interventions, kind of what programs are available on the federal and the state level, some barriers to treatment as well that kind of prevents people from either like looking into or accessing mental health and substance use treatment. So I think we skipped a slide.
Oops, sorry.
Oh, no, it's okay. All right. So to start off, the federal role in mental health treatment. The federal government works in partnership with the states to address mental health. The federal role in mental health includes regulating systems and providers, protecting the rights of consumers, providing funding for services, and supporting research and innovation. As a major funding source for mental health services, the federal government also establishes and enforces minimum standards that states can then expand upon. So some of the, like, to break that down a little bit more, some of the things they do is federal legislation and regulation. So obviously regulations are rules issued by the federal agencies to help implement the laws. In terms of mental health, regulations cover a variety of topics and apply to a number of groups such as schools, insurance companies, treatment providers, and employers. Federal protections, the government works to protect the rights of individuals with mental health disorders in a variety of settings, including the workplace, school, and in treatment. It also sets privacy standards, which like prohibits abuse and fights discrimination to promote civil liberties and inclusion. It works to provide reasonable accommodations and support to those who need them. The federal government also plays a really big role in funding services, specifically for mental health. In addition to funding mental health services that fall under Medicare and the Department of Veteran Affairs or the VA, it also matches state Medicaid and like children's health insurance programs, typically spending between 50 to 70% depending on the state. While these programs do not like exclusively focus on mental health, Medicaid is the single largest funder of mental health services in the country, which makes it extremely valuable. The federal government also provides mental health block grants that promote states building out like community programs and additional supports. In regards to research, the federal government funds mental health research that creates opportunities to study causes of treatments for and recovery from mental health disorders that might not otherwise be available. These include government agencies like the National Institute of Mental Health or the Substance Abuse and Mental Health Services Administration, which we heard from earlier. They lead research, administer grants, and educate the public about the findings from the research. This information contributes to our overall understanding of mental health disorders and services and can ultimately improve treatment and future research. So some of the federal interventions that are offered federally is NAMI, or the National Alliance on Mental Illness. So their goals and kind of their mission statement is to educate. So they offer educational programs across the country for families, individuals, and like support groups. So all kinds of things. They offer support. So they actually host support groups for both people that struggle with mental illness and for the people who care for them. They advocate. So a big role is to shape public policy for people with mental illness. They do a lot of stuff in regards to like new laws and things that are being considered on like a federal level. They maintain a helpline that provides information and support, and they also organize a lot of public events and activities to spread awareness of mental illness. One of their biggest ones is like the NAMI Walks event that they do. I believe it's once a year. So some additional federal interventions and programs are the Substance Abuse and Mental Health Services Administration, which we heard from earlier, and all of the services that they provide. They host the findtreatment.gov website, which was built to help individuals locate treatment within their zip code. So it's a super user-friendly website that you just put your zip code in and it'll pull up providers and treatment services within so many miles of your area. The SAMHSA also has the 24/7 free hotline that offers treatment referrals, support, and information about mental illness and substance use. It's not a crisis line, it's more like an informational line or just for like basic support. They offer funding. So like I mentioned in the previous slide, they provide grant funding to states, cities, and programs to support improvement of mental health resources. And they also offer a lot of oversight. So they collaborate and evaluate agencies and treatment programs to improve those programs and policies. So in regards to crisis lines, there is the nationwide suicide prevention hotline is kind of what it used to be known as and used to be called. They've recently like rebranded and changed their name to 988 Suicide and Crisis Lifeline. So this is a 24/7 around the clock service where anyone can call in. They provide free and confidential support for anyone that's experiencing like suicidal thoughts, a mental health or mental health crisis, and or any kind of substance use crisis. They also have a new service where you're able to access them by sending a text to the 988 number. We're using a chat feature on the website, which is excellent because not everyone feels comfortable talking about this kind of stuff on the phone or for privacy reasons. And as I mentioned, this was previously known as the Suicide Prevention Hotline, which was originally created in 2005, but recently they did change their name to this 988 Lifeline. So that was kind of the federal involvement. And so breaking that down a little bit further into the state role in mental health treatment. States have significant power in making decisions about their mental health systems, so mental health regulations and available services can look different from state to state and even from county to county, which Zoe spoke quite a bit about. State mental health systems must meet certain standards set by the federal government, but then those states are free to expand beyond kind of what exists at the federal level and improve services, access, and protections to consumers. So I'm going to go back. So the state role in mental health treatment, some of the specific things that they offer, very similar to the federal level. So state legislation and regulations, I'm sorry. In terms of mental health, state regulations can address a variety of issues, including specific treatment facilities, patient medical records, and standards of involuntary treatment. As Zoe talked about, that whole like Chapter 51 involuntary treatment process does vary state to state. The rules that these rules help states to implement their mental health plans and provide guidance as to what is and what is not allowed under their law. They offer state protection. So states follow the protections established by the federal government, with many states increasing protections further. This can be from like workplace to schools to treatment facilities. States have the power to increase standards for protecting patient privacy, fighting abuse, and for eliminating barriers and discrimination for patients. This ranges from discretion over civil commitment standards to determining like duty to warn laws, which we didn't talk much about, but just duty to warn laws are typically for treatment providers of all levels that are like made aware by a client that, you know, they may be wanting to like harm somebody else or having homicidal ideations towards somebody else, and their majority of states, if not all states, have a duty to warn law that requires us to then attempt to reach out to that person that may be in danger. So yeah, so that's part of like the state protections and kind of how those laws are all played out. States do a lot of funding for mental health services. So this varies greatly across the US. While all states receive federal support for like, or I'm sorry, by mental health block grants and partial funding of services through like Medicaid and other federal programs. Each state has the freedom in designing and funding its mental health care system. In addition to funding state hospitals, state funding is typically funneled to county and local levels where the actual services are provided. Depending on the state's political and economic climate, states will play a more or less substantial role in funding comprehensive mental health services. Lastly, the state level does quite a bit of research. Because of the variety in services and delivery of services, state to state, states try to report the outcomes of their treatment and kind of what they're offering in their state. States often use models or areas that have been successful and filter programs upward, expanding them in size or to other regions of the state based on the research and kind of studies that they do. This flexibility can create examples of new or improved programs that then can be implemented around the country. State-funded academic institutions also play an important role in fostering this research. So some state interventions, kind of going back to the 988 Lifeline, there is a specific 988 Suicide and Crisis Lifeline for Wisconsin. So this is where like anyone who calls the line would be directed to a local in-state person. The same kind of thing, this lifeline is used for people who are struggling with like suicidal thoughts, a mental health crisis, a substance use crisis, to get support and like additional resources. The counselors that work at the Wisconsin Lifeline are trained to reduce stress, provide emotional support, and connect people with local resources in real time. This is a free service and is available at no cost to any Wisconsin residents. The Wisconsin Lifeline does not send in-person responses directly, so they're not going to send like a counselor to your house. They are able to, like if you're in imminent danger or there's a concern that you may harm yourself or someone else imminently, they are bound by law to like reach out to law enforcement to actually come to your house, but the crisis line themselves is not going to come out to an individual's home. Any calls, texts, or chats with the Wisconsin Lifeline are kept confidential between the person and the counselor, again, unless there is that imminent danger for the person or others. So these are some local Wisconsin state programs that we have available. So a big one is the Wisconsin Department of Health Services, otherwise known as DHS. So kind of their mission is we supervise Wisconsin's public mental health system. Wisconsin's 72 counties are responsible for delivering services and providing for the well-being, treatment, and care of individuals living with mental health concerns. This often is done in partnerships with community-based agencies and organizations. So kind of under them, they have the county mental health, which is a facility that offers that offers a psychiatric emergency room and hospitalization. They typically also offer drop-in or access centers for the uninsured or underinsured. Majority of counties have a county mental health facility. For some of the more rural counties, I know that they tend to share one like or centralized location as well. There's also the warm lines, which are peer-ran support lines maintained by local agencies across the state. Depending on the county you're in or the area of the state you're in, the day and hours and days that the warm line is available varies. This is a phone number that you can call. It's typically ran by peer support people and people who have experienced their own mental health crises or illness or substance use. They offer emotional support and crisis intervention. Some community programs, and I believe these are, a lot of these are offered kind of statewide, but again, it varies county by county. Specifically in Milwaukee County, these are really big programs that we work with a lot. So there is the Community Support Program, which is a case management services for individuals in the community with serious and persistent mental illness. This is somebody like the patient or the person is assigned a case manager that they meet with weekly, monthly, kind of depends on what's going on. This person might help with like medication management, transportation, just to try to increase their access to care in the community. There is the comprehensive community services. This is a very similar program, but this is for individuals who are struggling with mental illness and co-occurring substance use issues. And then there's community recovery services. This is community assistance that connects individuals struggling with mental illness to supportive living, peer support, and a supportive like employment opportunities. So all these programs fall under the like Milwaukee County or county interventions that are available. And they're, like I said, kind of made to increase accessibility and to offer support in the most like, or in the least restrictive ways for patients. Some crisis services. So again, this is kind of biased towards Milwaukee County. I'm not totally sure on which of these are available in like other counties. I know just from my experience, there's some peer-run respites throughout the state, but we have a few in Milwaukee County. So our crisis services, we have crisis mobile team. This is a team typically that's 24/7 that is able to be dispatched to hospitals or the community when crisis line staff or law enforcement cannot resolve a crisis. So this might be to help with de-escalation or for somebody who's being placed on a Chapter 51 to offer additional support to law enforcement, like in managing that situation. This service provides in-person response and support. It's typically the staff on the crisis mobile team typically tends to be like mental health professionals that are trained in crisis intervention. We also have peer-run respites, which are facilities that provide overnight accommodations, and they also frequently run the local warm lines that I spoke about. These are ran by individuals with lived experience. Facility provides support to individuals experiencing a crisis due to mental illness or substance use. These, when we use the word crisis, these are not typically resources for people who are actively experiencing like suicidal thoughts or homicidal thoughts or psychosis, things like that. This is more of like a peer support environment. So Milwaukee County has the crisis resource centers. These are kind of a step above the respite centers that I just spoke about. These are facilities that offer community-based psychiatric crisis intervention. They're typically staffed by mental health professionals. The goal is to be used as an alternative to emergency rooms or inpatient hospitalizations. These facilities are open 24/7 and, like I said, are typically ran by licensed clinicians. Individuals are offered brief stays, assessments, stabilization, group therapy, and connection to appropriate follow-up care. So this tends to be patients who struggle with like chronic mental illness, sometimes chronic substance use issues. And you know, they may be doing very well on like an outpatient level and have a crisis come up or a situation come up where they need a little bit more support, but don't need to be necessarily in an inpatient psychiatric unit or hospitalized. So these crisis resource centers offer group therapy. They also offer a lot of referrals to some of those other programs I was talking about, like the community case management, to try to up the support in the community for these individuals. So barriers to treatment. Oh, uh-oh. Okay. So I am sure we know about quite a bit of these, but I did just kind of want to run through them. So a study in 2021 of 50,000 people showed that 95% reported at least one barrier to accessing mental health services. So we currently have providers shortages. So right now, more than half of the U.S. Counties lack a single psychiatrist. And estimates are that within a few years, the country will be short between 14,000 and 31,000 psychiatrists nationwide. There are excessive wait times, a lot of times related to the provider shortages. The increase in wait times due to not there's the increase in wait times due to not enough staff, but also as a lot of clinics are also at max capacity. People that may already be hesitant to engage in treatment are less likely to show up to appointments that are weeks to months out. Lack of transportation, this is especially relevant in like more rural areas where there is limited public transportation and or the clinics and facilities may be like quite a bit away. There's also the recent issue with affordability of gas and just like the financial aspect of that. A big one is stigma and shame. So there are two types of stigma, there's three types of stigma. So there's the public stigma, which is a cultural or racial belief in negative belief in accessing mental health treatment. This also could include judgment of family or friends. There's institutional stigma, which is like insurance companies and insurers paying less for mental health treatment versus medical treatment, or medical providers viewing psychiatry, psychology differently from other doctors. There is self-stigma, which is fear of not being sick enough, or kind of a why bother attitude, I'm not going to get better, as well. There is distrust of the system. So in the United Kingdom, for instance, in 2014, found that African American people had lower rates of mental illness than other ethnic groups. They were more likely to be despite this, they were more likely to be diagnosed with a severe mental illness, 3 to 5 times more likely than any other group to be diagnosed and admitted to a hospital for schizophrenia. And I believe this was also touched on with our last speaker as well. So due to this and the systematic racism that goes along with it, there does tend to be a distrust of the system. There are immigration status, so fear of law enforcement and involvement due to their immigration status can also deter people from seeking services. Active substance use may also deter individuals from seeking mental health treatment due to not currently being ready to change their substance use. Substance use also typically will reduce insight into mental health systems by masking mental health systems with their substance use. And finally, lack of insight. So sometimes mental health systems, notably like psychotic symptoms or manic symptoms, limit one's insight into their illness and need for treatment. And I think that is it. Yep. All right, I don't know how to do this. Oops.
Zoe, Ashley, do you have some time for questions?
Sure.
Okay, 1 second.
There it was.
We have a question from Kristen. Can you provide context for peer run respites in the Milwaukee area specifically? I can't even say that word. in the north side of Milwaukee.
Yeah, I can put my email here in the chat, and if anyone needs any follow-up questions, please feel free to give me a email and I'll send that out.
In regards to specific respite, so there's the Parachute House, and I believe they opened one other one. The Crisis Resource Center can also act as a type of respite for individuals, and they have a location directly on the north side of Milwaukee.
Owens Place is also for those 21 and under.
Perfect. Zoe and I both have lists of all the resources available, obviously.
I stepped out earlier. Allison had a question. It says, are the marketplace costs, and that was for you, Zoe, referenced recent, or were they from prior to the 21-22 Biden administration reduction in marketplace plan costs?
Yeah, these were what I just looked up through the marketplace insurance prior to our presentation.
And there are no more questions as of now. So thank you, ladies.
Thank you.
We do have one from Jenny. It says, do you also by chance have any cultural specific resources referenced in the area?
We have a couple that are some specifics. Again, if you wanted to email me, I'd be more than happy to send some of that stuff out.
Thank you, Zoe and Ashley. All of us at the National Association of Health Unit Coordinators and Froedtert Hospital appreciate you sharing your knowledge. I would like to thank all 4 of our presenters today for their time and dedication, not only to this webinar, but to the field of mental health. Each attendee today will receive an invitation to a feedback survey in their inbox. This will not only provide the valuable feedback we need, but will also be your application to continuing education credits, so please don't discard it. Information will be on the next screen, and we'll keep it up for 15 minutes. I hope everybody here found this information valuable and useful, not only to your workplace, but to yourself as well. Thank you all for attending, and we'll see you next week. Thank you for watching this webinar. To earn NAHUC content hours, visit www.nahuc.org, that's www.nahuc.org, and look for the Education Continuing Education tab. Click on NAHUC's Virtual Lending Library to access the post test and instructions on how to submit to earn NAHUC content hours. Email office@nahuc.org or call or text 815-633-4351 with any questions. All of this information is on this slide. Thank you.